Morning, Councillor Danko. I cannot hear you.
Good morning, everyone. We're just going to do a sound check. Sound check on the clerk's laptop. Sound check presenter's laptop. Thank you.
I saw you, Councillor Danko, yesterday in the
think we're going to go live. We are live. Thank you. And I'll call this meeting to order. And members of the public are advised that our meetings are webcast live by the City of Hamilton and temporarily archived on the city's website. And a reminder that all electronic devices are to be kept in a non-audible function. I'm going to go to a roll call to see who is present for our Board of Health meeting. I'll start with Councillor Wilson. Okay.
Good morning, present.
Good morning. Thank you. Councillor Farr. Councillor Nan.
Good morning, present.
Good morning. Councillor Marula.
Present.
Thank you. Councillor Collins.
Here.
That didn't sound like Councillor Collins. I heard Councillor Collins as well. I'm going to go pass right by the noisy one. Councillor Pauls. Okay. Councillor Danko.
Present.
Councillor Clark.
I'm here.
Councillor Pearson.
Present.
Councillor Johnson.
Good morning.
Good morning. Councillor Ferguson. Not yet. Councillor Vanderbeek. Councillor Whitehead. Councillor Partridge. All right, I believe we have quorum in the room. Thank you for your attendance. And Councillor Jackson, did you want to just acknowledge that you're present?
Present, sir.
Oh, speak softly, but carry a big stick, they said once upon a time. All right, members of the board, thank you for your attendance. Are there any declarations of interest? Coming. And now the approval of the agenda. A mover to approve the agenda as presented. Okay, Lauren. Oh, I see that, but are there any? Oh, okay.
Oh.
Madam Clerk, any changes to the agenda, please? I didn't think there were, so I glossed right over that. Sorry. Go ahead.
Thank you, Mr. Mayor. We have two items, in fact. We have an added delegation request from Kaylee Metler respecting the 5G rollout, and also just published and to be presented today will be the COVID stats from March to the present day.
Okay, thank you. So then a motion to approve the agenda as amended, moved by Councillor Clark, seconded by Councillor now Vanderbeek, present. To be marked present, I see you, thank you. All in favor, electronic vote, please. And we are going to go on mute for everyone, correct? Votes coming at some point. There it is.
Mr. Mayor, it hasn't appeared for me.
Yeah, there isn't a vote showing, but it shows.
My apologies, Mr. Mayor. I did not take roll call on eScribe, which will delay this. So give me one more second, please.
You have to put everybody in manually. Oh, that'll take a moment or two. And I didn't hear any declarations of interest, correct? No indicators, thank you. Okay. There is a vote. If you're having any trouble, let me know. Seems all is working well.
It hasn't appeared for me, Mr. Mayor.
Hasn't showed up for you? Okay, just give me the thumbs up and we'll figure it out. Thank you.
Okay.
Got it. Thank you.
Okay, no worries. Thank you. And that's carried. Members of Council, There has been the minutes of the approval, to approve the minutes of September the 21st meeting. I have a motion to do that, moved by Councillor Nan, seconded by Councillor Ferguson, now present. All in favor? I see no one's willing to speak on the minutes. I saw a lot of movers and seconders though. Here we go. Someone has arrived. Okay,
I'm here, Mr. Mayor.
thank you. Good morning. We'll mark you as present. And is that carried, Lauren? Councillor Nan able to vote? Yep, she said she was. Sam Marula, thumbs up.
Councillors, it's just Lorraine from the clerk's office. If you are not seeing the vote, I would suggest you refresh your screen, which is Control F5.
Carried, thank you. Then I'll move on to communications, items 5.1 through 5.2. Any comments or questions on communications? Anyone? Councillor Nan, go ahead.
Thank you. Through the mayor on 5.1, glad to see that it is to endorse the correspondence coming from the other region. Sorry, I'm just toggling between screens here. In terms of the Simcoe Muskoka District Health and the call for support in endorsing the long-term care reform. There are 9 specific policy outlines and 9 steps that require better coordination from a federal, provincial, territorial, and municipal leadership in terms of coordination there. And I think it's really important that we do give residents a chance to really understand the impact. I think a lot of folks have been able to see it in the first wave in terms of how COVID-19 exposed our LTC program and operations as being insufficient from a policy perspective, but most importantly from a coordinated approach perspective. So I'm glad to see this come forward for endorsement, and I think it's critical, and I'm glad to see that we'll be able to do that today. On correspondence 5.2, I assume that we'll get a bit of an update in terms of how this is integrated in with the subsequent reports that are coming. But it's good news in terms of $25,000, but it also seems like a bit of a drop in the bucket, $25,000 one-time critical mental health and addiction services due to COVID-19 related impacts. And I guess my question was, based on where we're at as a municipality and what we're facing in terms of mental health and addiction needs and how COVID-19 has exacerbated it, I'm just curious what this 25K will enable for our region in terms of a better health response. And if that is going to be addressed later in one of the reports, I'm happy to pause there. And if not, if I could get a response to that, I would appreciate it.
Thank you. Dr. Richardson?
Thanks very much, Councillor. And as you're saying, very correct in saying that the mental health impacts from COVID-19 are significant. This particular one is to support some smaller dollars for this particular agency. I'm just wondering, with this particular part of our agency, I'm just looking for Michelle. I don't see her on.
I'm here.
You're there. Good. There she is. Just to speak to the specifics.
Thank you.
Thank you. Through you, Mr. Mayor. So this particular funding, Councillor, is specific for the ADGS program, so Alcohol, Drug, Gambling Services. You are correct that it is a small amount of money. However, this work goes toward our addictions program. So for adults with addiction services, that's what this specific funding is for. It covers a portion of a salary of 2 of our social workers, 0.4 and a 0.2 increase. And so this program, you'll know we brought a report back at our last meeting, We had some anticipated staff reductions there as a result of a stagnant budget, basically. So this will help us offset that and continue those addiction services.
Thank you. Much appreciated.
Great, thank you. Any other speakers on items 5.1 or 5.2? Okay, can I have a motion to approve them as presented? One endorse and the other one to receive. Moved by Nance, seconded by Pearson. All in favor? Electronically, as soon as Lauren gets it up there. Anyone having difficulty voting? Lloyd, thumbs up then? Thank you.
Could I just ask a question of the clerks on this? What's coming up on my screen now? Can you hear me okay?
Can hear you, yep.
Perfect. So what's coming up on my screen is a correspondence item. Who is moved by, seconded by, and then there's a prompt to close it. Is that new? And what are the steps I should take then? I've tried pushing F5 to reboot this thing. My computer took 20 minutes to fire up this morning too. That's why I was late coming on. So do I just hit close?
Lauren?
It just disappeared.
Okay.
Counselor, sorry about that. It's Lorraine here. I just need to mark you back into the roll call, and then the votes should appear to you just fine. So just give me a moment, please. Thank you.
Okay.
Mr. Mayor, the very same thing's been happening to me. I've tried F5 and the very same screen is coming up that Councillor Ferguson just described. Thank you.
Okay.
Not to prolong the problem, Mr. Mayor, but I'm also in that same boat. So I'm just, okay, thank you.
So obviously the same resolution for everyone would apply, I would assume. So let's see if we can sort that out. Sorry? Okay, you're being asked to refresh your screen.
I've done it. Yeah, I've done it.
Done it?
I've done it also. There, it's coming up now.
All right.
Well, mine isn't. Let me try again.
Mr. Chairman, I've rebooted twice and
we'll just go manual.
Yeah, take it manual.
Mr. Mayor, I'm fine. I'm fine with manual.
Yep.
Me too.
And so I'll take a thumbs up and a thumbs up for Councillor Clark and Ferguson. You were able to vote, Councillor Ferguson?
Yes, I was.
Okay, thank you. Anyone else have a problem? Okay, the vote should come through and we'll hopefully have everybody recorded. Thank you, and that's carried. And we have a delegation request for the next meeting, our future meeting, delegation from Kaylee Metler, respecting a 5G rollout for a future meeting. Members of Council, the approval to move that. Moved by Clark, seconded by Johnson.
I have a question.
Question? Councilor Clark.
Just when that delegation comes back towards us, can we have someone from staff refresh our memory in terms of what our role and responsibilities is with 5G as a municipality, please?
Yep, thank you.
Thank you.
Councilor Ferguson?
Yeah, I've had a lot of correspondence, I suspect everyone has, from the correspondent on this requesting the delegation status. So just a quick question right now, and I'm like Councillor Clark, I'd like staff to be prepared for this when they come to the next meeting, but a quick question, and Dr. Richardson could deflect this to the right individual. Bell is just about finished installing the 5G fiber. A lot of it has already been activated throughout Ancaster. Ancaster was the first to get done. We were the Mikey of the group, and we'll have 1G up and running in our rural area wirelessly. Has our health department done an analysis of 5G and find out if there's any health issues around this? Because I'd like to know that since we're going live in my community right now.
Doctor?
Through you, Mr. Mayor. No, we haven't done an analysis of 5G as of yet. Our understanding is I believe Public Health Ontario is doing an analysis that's underway. We would normally wait for analysis from a higher level if we knew that it was going on, or from a colleague if they were undertaking it. And actually at this point, we don't have the capacity to do that analysis.
Okay, Doctor, is there some way you could have something about this from a higher level of government by the next meeting when we hear this delegation? Because we need to deal with it or put it to rest based on the medical evidence on it.
Through you, Mr. Mayor, I don't know PHO's timeline. I'm just going to turn to Kevin and Bart and see if they have an idea of what their timeline is for completing that?
Thanks, Dr. Richardson. Through you, Mr. Chairman. No, I don't have a timeline from Public Health Ontario.
And the communication that I had with Public Health Ontario is they were well on their way, and then COVID came along, so they also have been a bit sidetracked. They've had some senior retirements, but I'll check back to see if they've been able to make any more progress. They know that we're very interested.
So, Dr. Harvey, do you believe there's any risk to the public on 5G? Because Bell got approval to go ahead and install this in Ancaster.
I think it would be premature for me to try to make a declaration on that. It's
okay.
New technology. It's similar to old technology, but it's new technology. So, you know, I think as Dr. Richardson has alluded to, knowing that Public Health Ontario has already begun a review on this to share with the rest of the province, I think that's the way to go.
Okay, because the correspondent, I don't know what her qualifications are. It's not in her letter to us, nor in her previous emails to us, but she says we're putting the community at big risk. So if you could have that, there's something for the next meeting, I'd appreciate it. Thank you, Mr. Mayor.
Thank you. Councillor Partridge?
Yes, thank you, Mr. Mayor. And I've been dealing with a resident in my area, and Cyrus in our IT department or in the corporate services department, I believe, has been assigned this file for the internet. And it was my understanding through various correspondence back and forth with Cyrus and with the resident that there is no 5G throughout our city as of yet. And I'm not really sure, so my question is, should we not have more information from our staff? But my understanding is also that the folks that are, the person from my area who's submitting the letter is a concerned citizen. They're not a particular expert in this area. So it may be the same situation with this letter writer. It's not to dismiss it, because anytime a resident is concerned, it's certainly something we need to take seriously. But, so I think if we can have Cyrus on the next call or the next meeting, that would be helpful. Thank you.
Thank you. So Bell's rollout is Ancaster first, and then it rolls out into the rest of the broader community. So their commitment has been to do 5G throughout the city of Hamilton to the tune of some $400 or $500 million investment. So that's going to be ongoing. But we certainly can hear concerns from residents out there in terms of their perspective on impacts, and Cyrus has been the lead in that entire process, and so he certainly would be a helpful resource to get information from. Dr. Richardson, you wanted to add anything else? I thought I saw your hand flicker up there.
No, sorry, Mr. Mayor.
Okay.
I was just changing something on my screen.
Just swatting a fly. Okay, thank you. So to approve the delegation coming at the next future meeting, moved by Councillor Partridge, seconded by Councillor Danko. All in favor of that electronically, and others that need to go manually? Vote popped up. Councillor Marula, did it pop up for you? Okay, thumbs up from you. Thank you. Anyone else? Thumbs up from Councillor Partridge. Thumbs up from Councillor Clark. Thank you. Councillor, nope, we got it. Yep. All right, that's carried. And Dr. Richardson, you're here to speak to the 2019 Public Health Services Annual Performance and Financial Report to the public. So Dr. Richardson, take it away.
Thanks, Mr. Mayor. So this is our 2019 annual report that we're required to do under the Ontario Public Health Standards each year. We don't limit the report simply to the Ontario Public Health Standard programming, but do expand it to all the programs and services that are provided.
Uh-oh. Houston, we have a problem.
Online format only.
So, Doctor, your audio is going in and out.
Mr. Mayor?
Yeah.
Is it?
So something's not clicking. Your screen is freezing as well. So you might want to check your connections. Seems to be okay right now.
Yeah. Okay. Still having problems with this computer then and my connection.
She said shutting your video down might help you, but then we can't see you. I think it's trying to boot up again. Are you there?
I'm here. How's that
Yeah,
now?
there you are. Well, let's marshal on and see how it works.
Okay, I just need to disconnect from the VPN, unfortunately, so I have no email or other city access. That's the challenge. So as I was saying, Mr. Mayor, this is our 2019 annual report that we're required to do under the Ontario Public Health Services requirement, but it addresses all of our programs and services, not just those provided under the Health Protection and Promotion Act. We did move to an online format this year, in order to make it very accessible, but also to reduce paper and printing costs and all those sorts of things. So you'll see it's a little bit more of a plain Jane, perhaps, than prior years in terms of not as much visuals and whatnot. We will add those in a little bit more so next year when we have a little bit more time to produce it. It does go through and highlight important programs that are going on within each of our priority areas. So health equity, healthy weights, and so on. So lots of information there. We always do also present a number of sort of facts and stats at the end in terms of our programming and the number of inspections, for example, and have started to include as well, whether they've been going up or down in terms of the numbers that have been achieved in that year. So you'll see, for example, that the number of residential care facility inspections had been down in 2019 compared to the prior year. That was because of staffing issues that we've continued to have in that program and led to some of the changes that this Board of Health approved in this past year to try and make that work a little better. But of course, COVID-19 has also gotten in the way a little bit in terms of that particular program. So there's also some facts and stats on funding that we post, and that about covers it.
Okay, thank you. So any comments and questions on the report itself? Seeing none, could I just ask, I mean, a number that jumped out at me, Dr. Richardson, is people reported as being revived by public health naloxone kits. And I see the number on your Appendix A as 568 in 2018, 2,214 in 2019. Now, is that a result of our success to get those naloxone kits out there, or are we seeing that kind of an increase in incidence of people needing naloxone? How do we define that incredibly 290% jump in people being revived from naloxone?
So it's, I think it's probably a bit of a combination of both, since we've seen our number of naloxone doses distributed triple, increased by almost 200%, I should say, over in 2019 over 2018. And then, as you said, those kits are definitely being used by people to revive them. Some of it is as well, we've seen some resistant drugs that require 2, 3, 4 sometimes kits to be used in order to revive. But I'll just turn to Michelle and see if she has anything to add.
Okay, thank you. Michelle?
Yes, Mr. Mayor, these numbers on the numbers of people revived, those are self-report numbers to us from our clients when they come back to pick up another or a new naloxone kit. So we are likely seeing an increase as a result of both. We certainly are seeing an increase in our community and have over the past few months now on the number of opioid incidents in our community. And as well, we've greatly increased our distribution, which is good news. So we're seeing that increase in use, partly because we're giving out more naloxone.
Okay, thank you. Is there an expiry on a naloxone kit? Does it have a limited lifespan? And is that measured in months or in years, or?
Right, Michelle.
You know what? I don't know the answer to that question, Mr. Mayor. I can get back to you on that.
Okay, I appreciate that. Thank you. I don't have any further questions, but great report, and thank you for that. Any other questions on the report as a whole? If not, a motion to receive the report. Moved by Pearson, seconded by Clark. All in favor for those that can, and I'll take thumbs up in a minute. Or opposed?
Mr. Mayor?
Yes, sir.
It's Councilor White. My camera is not working for some reason, so I'll let you know. I've been trying to get.
Okay, thank you. work on that, and you're approving of this report?
Yes, thank you.
Thank you. And Councillor Marula, thumbs up. Councillor Clark, thumbs up. Councillor Partridge, thumbs up. Thank you. Anyone else need to do that? And that's carried. Thank you. And now to item 9.1, which is the overview of COVID-19 activity in the City of Hamilton. Dr. Richardson, over to you again.
Thank you very much, Mr. Mayor. And to the Board of Health, this is a rather more evolved presentation this time around. Essentially, what we are doing is bringing to you each month the status of the epidemiology around COVID, so the cases, the trends we're seeing, those sorts of things. And Steph's going to continue to do that for us each meeting. We also, in this particular presentation, have for you an overview of the SPINCO outbreak as an illustration of what can happen, what is happening around COVID-19 spread. So you'll find during that particular part of the presentation that will give you some more details about what has come of an outbreak such as this. And it's by no means to say that this is specific to SPINCO. In any case, there are outbreaks that that happen and have these kinds of connections. And we've seen these kinds of diagrams be presented in London, for example, in relation to a university outbreak. We've seen them presented in Ottawa in relation to a barbecue in a park. But it is a very important way to get across the challenges with COVID-19 and the importance of following public health measures. And so that's why we're presenting it to you today. You may notice that we don't provide every level of detail, and that's very intentional. So as the health information custodian for the board, I'm required under the Personal Health and Information Protection Act to make sure that any information we provide does not violate people's privacy. We are permitted, where it's important for public health and for people to understand what measures they need to take, to give a little bit more information, and that's what we have done throughout this pandemic and are doing here today. But we can't give more information just to satisfy people's need to understand or desire to understand exactly what might have happened. Where we get to the point where it's unreasonable to do that, we have to stop. And so you may ask of us today some questions that are very tempting to say, well, can't you just tell us if this is connected or that? And we've been very, very thoughtful about that. We have consulted with our privacy officer about that, and we've gone as far as we can. So I just want to give that preamble because it's Mackenzie, who you've seen before, goes over it. As I said, you may be tempted to ask us to go into a lot more details, and that's why we're not. Of course, ask some questions, but if we have to say to you, sorry, we can't give you that one, that is why. And then we tried to write a report for you on the status of our programs and services and where we were at in terms of the COVID response and the number of people deployed. The challenge is it changes every day. And so we realized doing this as part of this presentation was much more timely and up to date and accurate at the time of the Board of Health meeting than trying to write a report. So that's the third part to the presentation that you're going to see today that I'm going to present. I'll just make a note as well, the broader social determinants of health report is following on. And so I'll come back and speak to that a little bit more at that time.
Okay.
So with that, Mr. Mayor, I'm going to turn it over to Stephanie.
Great, thank you.
Okay, thank you very much, Dr. Richardson. Okay. All right. Good morning. Thank you very much for inviting me to present again. I'm very happy to be here. Today we'll be presenting a COVID-19 situation report and status of programs. Right, so similar to my previous presentation in September, this presentation will be broken up into two parts. So an overview of case activity. So this will include the description of the phases of COVID-19 that we've seen here in Hamilton, the trend of daily reported cases, and also age distribution. And then this will be followed by an overview of outbreak activity. And it's important for me to note here that the information in this presentation is current as of last Friday morning. So the first case activity. So COVID-19 activity in Hamilton can really be divided into 4 distinct phases. So in wave 1, we have phase 1. So this is pre-peak. This is from March until the very end of March. So during this phase, nearly all of our cases were travel related. If you recall from the September meeting, I presented the process that we use to determine where a case caught the virus, so how we categorize our cases. So the first is the case associated with an outbreak? If no, then is the case related to travel? If no, then is the case a contact of another COVID-19 case? If no, then the case is then deemed source undetermined, or what we refer to as community acquired. It was during this phase that we had our first case reported, our first outbreak commence, and the first case identified with no source determined. Furthermore, testing criteria were very strict at the time. When looking at case statistics during this phase, we had a total of 111 cases reported to Hamilton Public Health. We had 2 deaths, and we had 14 cases hospitalized. A total of 609 tests were completed at Hamilton Assessment Centers, and this is after they opened on the 16th of March. So looking at phase 2, so this is what we refer to as the peak. This is from April 1st through May 31st. During this phase, there was a bit of a shift away from cases being due to travel, and it was a shift towards people catching the virus from contact with other known cases of COVID-19. There was also an increase of outbreak activity. So a total of 32 outbreaks commenced, which resulted in an increase of cases aged 70 or greater. The majority of outbreaks were in long-term care homes or retirement homes. However, I will be presenting this in a few slides later on in this presentation. So near the end of May, outbreak activity calmed down a little bit, and activity amongst the younger individuals, so those individuals aged 20 to 29, increased. When looking at case statistics during this phase, we had a total of 568 cases reported to Hamilton Public Health, 36 deaths, and 121 cases hospitalized, as well as a total of 9,060 cases completed at our Hamilton assessment centers. During phase 3, so this is post-peak of wave 1, this is from June 1st to July 31st. During this phase, we continue to primarily see cases that were due to people being in contact with other known cases of COVID-19. And we also saw an increase in cases with no known sources, so what we call community acquired. Outbreak activity remained very low. Only 1 outbreak commenced during this time. We progressed during the stages of provincial reopenings, and with that, we saw increases in socialization amongst Hamiltonians and clusters in households. When looking at case statistics during this phase, we had a total of 211 cases reported to Hamilton Public Health, 7 deaths, and 8 cases hospitalized. Testing volumes drastically increased during this phase, with a total of 29,146 tests completed at Hamilton Assessment Centers. So now, as we head into wave 2, so this is phase 4, so pre-peak once again. This is from August 1st until present. So during this period, we've continued to see cases primarily due to people being in contact with other known cases of COVID-19, and also cases with these undetermined sources or community acquired. Also during this time, schools have reopened, and we've seen our first cases identified in our schools. Ongoing socialization has been an issue and a key driver behind our case activity, and cases continue to occur in households and in social groups. During this phase, the recent increase in outbreak activity has also recently contributed to spread of disease. So 10 COVID-19 outbreaks have commenced, including our first declared workplace outbreaks and our first declared school outbreaks as well in local schools. So lastly, when looking at case statistics during this phase, we had a total of 590 cases reported to Hamilton Public Health, 2 deaths, and 13 cases hospitalized. Testing volumes have continued to be high, with a total of 55,624 tests completed at Hamilton Assessment Centers. So here, focused on our cases from phase 4. So as I mentioned on the previous slide, so this is from August 1st until last Friday morning. So August 1st to October 16th. This allows us to take a closer look at the changes in recent case activity. So this graph here displays the number of COVID-19 cases reported to Hamilton Public Health Services per day. So overall, case activity has been increasing in recent months. From October through about the middle of September, case activity increased in waves. So with between 1 and 5 new cases reported to public health per day. However, from the middle of September until the present, the number of cases reported to public health per day has been steadily rising. The number of cases reported per day is now approximately 27 cases. So when looking at the percentage of cases by age group, the largest proportion of cases are amongst the 20 to 29-year-olds, and the smallest proportion of cases is amongst those 80+ years of age. I will continue to monitor and present these age groups to you as we progress through the second wave of COVID-19 here in Hamilton. Okay, so part 2, looking at outbreak activity. So looking at a facility breakdown, so we've had a total of 44 COVID-19 outbreaks that have occurred to date. So this is from March through October. The largest proportion, so 15 out of 44, which is 34%, of Hamilton's COVID-19 outbreaks have occurred in long-term care homes. The total case count in retirement home outbreaks, however, have been higher than all other facility types. So there have been a total of 161 cases in retirement home outbreaks, and this is in comparison to 46 cases in long-term care home outbreaks. So when looking at recent outbreaks, after going several months with no declared outbreaks, Hamilton's last declared outbreak was at Community Living Hamilton mid-July. There were 10 outbreaks declared in what I've been referring to as phase 4. So 2 outbreaks were declared at long-term care homes, one at St. Peter's at Shadok on September 27th and declared over on October 6th, and another at Dundurn Place Care Center on October 11th. 3 workplace outbreaks were declared. The first was at Koi Restaurant on October 1st and declared over on October 5th, another at Cushy's Baby on October 13th, and the third at Radius Restaurant on October 14th. These were the first COVID-19 workplace outbreaks that have been declared in Hamilton. 2 school outbreaks were declared as well. So both the outbreak at Sacred Heart of Jesus Elementary School and the outbreak at Shannon Kustachin Elementary School were declared on October 13th. These were the first COVID-19 school outbreaks declared in Hamilton. And lastly, 3 outbreaks categorized as other were declared. So the first at Ragel Supports for Community Living on September 27th, which was declared over on October 9th. The second at Spinco Gym on October 5th. And the third at Salvation Army Lawson Ministries Assisted Living on October 9th. So now I will pass this over to my colleague, Mackenzie.
Thank you, Stephanie. Good morning, Board of Health. If I am having connection issues, please let me know. I might have to turn off my VPN as well if my connection or my video or my audio get a little shoddy. So I'm Mackenzie Sleafers. I'm one of the epidemiologists that works for Hamilton Public Health as well, and have been supporting the outbreak investigation with SPINCO. And so today I'm here to present an overview of the wide-ranging implications that this outbreak has had within the community, particularly the connections between SPINCO and a bunch of other settings across the city of Hamilton. So to date, we have had 74 cases linked to this outbreak, and that number is updated as of Friday. And so of these 74 cases that we have linked to this SPINCO outbreak, we have 48 that are primary cases. And when I say a primary case, I'm meaning that these 48 cases are SPINCO members who attended one of the impacted classes at SPINCO, and that was a likely place where they acquired their COVID-19 infection through going to SPINCO. So they have that direct connection in our outbreak. And so among these 48 primary cases, as you saw in Stephanie's previous slide, 46 of them are patrons and 2 of them are staff members. So these 48 primary cases are people that come from across our community, and so they are actually linked to many other settings throughout our community, including 15 secondary households, 8 schools and childcare facilities, 6 healthcare facilities, and 22 other workplaces, whether those are restaurants or gyms or retail stores, as some examples. So these, in many of these instances, these 48 primary cases may have either been employed at these settings or been additional patrons or visitors at these other settings across our community. But in many of these cases, that's where the 48 primary cases are linked to. And those cases, most of the time, that's where it stops. But in some of these settings, these additional settings outside of SpinCo, there has actually been what we've further spread. So there actually has been secondary transmission, where there could have been a primary case that then passes the infection on to someone who is not a member of SpinCo. And so actually across these settings, in some of them, so not all, I just want to make that clear, there have been 26 secondary cases. And so when I'm referring to a secondary case, I'm referring to people who are not a member of SpinCo, but likely acquired the infection from one of those 48 primary cases. And so in a select number of these additional settings, we have these 26 secondary cases. And I just want to note that this information is still preliminary. The outbreak is still going on, so it hasn't been declared over yet. And there still is investigation that is ongoing. So the real purpose of this slide is just to really show the wide-ranging implications and impact that a community outbreak can have when we're talking about COVID-19. So with that, I'm going to pass it over to Dr. Richardson to finish the second half of this presentation.
Thanks very much, Mackenzie and Steph. So just again on that, it does show us how wide-ranging, as Mackenzie said, the impacts could be, but also just how important it is that everybody follow those public health measures, the masking piece and the physical distancing piece, the not going out if you're sick piece, the hand washing, all of those sorts of things. And increasingly, as we have other regions in the province who are becoming hotspots, to ask them to stay within their zones rather than to move out to others as well. So I'm going to go on, and if Steph doesn't mind just flipping forward through the slides, I'll go on from there. So we have actually issued some additional control measures here in Hamilton as of beginning last Friday, and we'll do some more further today. So the first is a letter that we sent out to all long-term care homes, retirement homes, and residential care facilities. The province has updated what we call Directive 3, which is a specific directive that is addressing those, and particularly long-term care home environments and where possible to retirement homes. And we have extended that to residential care facilities. And so asking them under that directive to restrict visitors and absences, that is when residents to go out to other places as much as possible. So for visitors, really just those essential visitors who are necessary to help with care and connection, and then absences to restrict those for the most compassionate reasons. So that did go out on Friday, and our congregate settings group that works together across the healthcare system will be following up this week again with assessments in those sorts of facilities, and they'll get a handle on how far people have been able to go in meeting those restrictions. The next is around interim guidance for gyms, and so we have had further discussions with the province around what we saw in the outbreak, what we think might be reasonable changes to be made, and they have again continued to have those discussions at the public health measures table of the province, and those discussions are ongoing. So in the meantime, you'll have heard me talk about some of the things that gyms can do, like ensuring that that masks are worn actually through physical activity, because most people are able to do that. and other sort of interim guidance or interim measures. And so we're going to formalize that with a letter today that will go out to all gyms to make more formal the recommendations that we have. And so those are making sure that everybody is operating under what we call the ASHRAE guidance for these kinds of facilities. So that's around building heating, ventilation, air conditioning systems, making sure they're well maintained and are running well, ensuring that there's no shouting or singing that occurs in classes. To facilitate communications, fitness instructors should instead consider using microphones and work with the people in the class to make sure that they aren't joining in or that sort of thing. Further, we're going to make sure that physical distancing of at least 3 meters is maintained between people who are exercising in the facility. We're going to set a capacity limit of up to 10 persons, including staff per group inside any sort of fitness room, and ensuring that, as I said earlier, that anybody is wearing a mask even when they are engaged in physical activity. So we're going to send that out as interim guidance. We know a number of gyms have responded to this already and are putting in further measures. And this is some interim guidance while we await the full deliberation by the Public Health Measures Table based on not only our outbreak and what our experience has been, but others that they have seen elsewhere across the province. So just go to the next slide, Steph, if you would. So just reminding ourselves about what we, might see as we go forward. And the Ontario plan for the second wave includes these 3 different scenarios that might happen. So that's slow burn, where you see a smaller second wave and a few localized outbreaks that are quickly contained. And that's what we were hoping we were seeing. As you saw Steph show those earlier diagrams, we were hoping we were seeing with just very small waves, but we now do have a larger wave. And so that's the second potential scenario, where you see peaks and valleys with moderate second wave, some areas having little impact, others having localized outbreaks, and infections potentially happening again in congregate settings, which unfortunately has been the case in some other parts of Ontario. And the third potential scenario is the fall peak. So this very large second wave that may target, the anticipation would be that it would target again healthcare systems in areas with high population density, with regional and local outbreaks that are hard to contain, and severe outbreaks in congregate settings. And so that is the more severe scenario, which we are hoping doesn't come to pass, and is why we are working so hard to remind everybody that we have to figure out how to live with COVID-19, and that means taking some measures at all times. Next slide, Steph. So in terms of our structure, just wanted to let you know, if you recall from our report that we brought back in July, we outlined a need for more resources, as well as the need to move into an interim structure to deal with COVID-19. So this is actually our usual structure, our structure before this pandemic came forward, where you can see we had the 3 divisions, and we were carrying on a group of programs and services that very much reflected the Ontario Public Health Standards, as well as the additional programs and services such as ADGS, Child and Adolescent Services, and the like that we do here. Next slide, Steph. When we move into Incident Management System, or IMS, as we call it, and this is the sort of standardized structure that pretty much everybody follows within North America when they're dealing with emergency response, we move into this director for our public health EOC, and you'll see similarly at Paul's level, he's the director for the city EOC. And then we have 4 key areas in terms of the emergency response: operations, planning, logistics, finance, and administration, as well as an arm of the table that is overseeing the programs and services that are able to continue that aren't directly affected by the emergency and responding to the emergency. And then we have a communications function as well, with a public information officer, and in this case, more of a communications director as well. So we went into that structure in January and evolved it to fully be operating in that through until the end of the summer, when we started to evolve out of it, because we realized, the business continuity piece that was being managed was still fairly large. We have a number of essential programs and services that have to continue, and it's difficult for one individual to be overseeing the breadth of that. And as well, we realized we were in this for the long term, and so we needed to figure out a new way to organize in order to best support both the COVID response as well as our usual programs and services. And so that's when, Steph, if you can flip it up, we came up with this new structure for operating, which you'll see is a hybrid of both of those. So we return to the 3-division structure. We do have under Michelle's area in epidemiology, wellness, and communicable disease control, where that sort of work would normally reside. We do have a senior manager who's responsible for the majority of the COVID response pieces. And so all those green pieces that you see there and across the other 2 divisions are parts of the IMS system of working and focus and ways of working that are now integrated into our new structure. So for Michelle, large number of people working in that, and those people come from not only her area, but are the redeployed people as well that I'll talk about in just one moment. Within healthy environments, Kevin continues to oversee the communications function along with Jackie Durloff, who's our communications officer, who's ably handling communications despite the fact that there's many, I think she was at 30 inquiries on Friday, and they have, of course, extended North America wide now with CNN and Today Show and whatnot, calling Jackie for updates, which is it's a lot of work to do. It's very important that it's done very well, and Jack's just great at it. And you can just imagine the reach and the importance of the work that's done there. The last division is Jen's, which includes our planning and logistics functions. So she oversees the planning for what we think might happen in the future, as well as ensuring the resourcing of the ongoing response. So for example, Steph, if you don't mind, I'll use you as an example. When we realized we're completely into virtual operations for the long haul, the importance of visual connection throughout this. You'd asked before, Steph, could you turn on your camera at the last meeting? In this meeting, you'll see Steph has a camera, and we're all able to see her, and she's as well as her see all of us. And so just making sure that things run smoothly, whether it's the tracking and allocation of human resources or physical resources. Masks, for example, were a huge thing, and PPE at one point. So they continue to be, but we have those into more usual ways of doing it. So Jen oversees those aspects of that. I'll just get you to flip to the next slide, if you would. One of the things you've heard me talk about, and you'll have seen with the long-term care home piece, is the Hamilton COVID-19 regional structure. And so we do work with Ontario Health West, which is one of the 5 regions in Ontario under Ontario Health, which really brought together the former 4 LHINs here in Ontario Health West for HNHB, Erie St. Clair, Waterloo Wellington, and Southwestern Ontario. And we work together with all of them in a structure that is headed up by Mark Walton, who is the interim executive for Ontario Health West, and Tom Stewart, who is the co-chair of the regional response table. At the HNHB level, we have a triad of individuals, and it's a similar structure in each of Erie St. Clair's, Southwestern Ontario, and Waterloo Wellington, where we have a hospital lead, and that's Rob McIsaac, who chairs the group. Paul Johnson is acting as our community lead here in Hamilton, and myself as the public health lead for our HNHB triad. And we work with all of the hospitals, public health units, everybody, long-term care who falls under that, but have asked each of the regions, just like we do here in Hamilton, the subregions, to have a leadership table that works on the issues locally. And so here you can see the Hamilton COVID-19 response table with the public health, hospital, and community shared leadership model that you see at that HNHB level. And so that's Scott Wooder, Dr. Scott Wooder, who's a family physician from the community perspective. There is Melissa Farrell from St. Joe's Hospital Hamilton, who is on from the hospitals, and then myself again as the public health rep. And underneath us, we have a number of work groups, as you will see, working on everything from communications on a broader level to monitoring evidence and surveillance and capacity planning within hospitals and elsewhere. IPAC supports, so a whole range of things that are being worked on with partners from across the whole of the healthcare and community system. So with the refresh that we did of this coming into the second wave, it's greatly expanded its membership and people who are working together on these issues. And it's a lot of work that is ongoing at all those levels. Just so you know, Jen, as well, because of her planning lead for us, is a support along with Bethany Elliott to that COVID-19 response table. She also sits on, leads up our assessment and testing table and sits on the regional testing advisory committee at the Ontario Health West level. So that's just one example of just how many connections and busyness and responsibilities that people have from public health services throughout the broader response. And it's been really important to keep it connected, keep it working well, and effective as we go forward. You'll see as well, just in the top left, the connection to the Hamilton Health team. So we are very much connected there. Jeff Wingard and Melissa McCallum and Leanne all help to support both the HNHB triad as well as the Hamilton COVID response table. They're the supports to the Partnership Council and the Hamilton Health Team Executive. And we very much communicate with them and have drawn in much of the membership from there. But our direct reporting relationship is through the HNHB triad and to Ontario Health West. So hopefully that gives you a sense of the structure we're working on there. Our current state in terms of staffing, we do have a total of 232 public health staff and 4 city staff that are working in PHS on COVID-19. So of course there are many, many more staff working on COVID-19 related issues beyond PHS at the city level, but this is the total number that are working on the public health aspects per se. For some of these, it'll be part of their routine work. So if you think about infectious disease control and outbreak control, those are part of some of our staff's routine work, as is the epidemiologic support of those functions. But that gives you a sense of the overall number. Of the 96 FTE that this board approved for us to hire in the summertime, we have hired 64 of those. And so you may remember that the initial number was 75. So if you'll follow with me some bouncing balls on the math for one moment, we had 75 that were approved to be hired at that point in time, as well as a further 17 for the assessment center, which I'm going to address in just a minute. And then we did get a further 21 FTE of school COVID-19 nurses from the provincial level. So that's what makes up the 96. So to date, we've been able to hire 64 of those individuals, and the recruitment of the remainder is ongoing. I will say that onboarding and training of those is significantly time consuming. It's one of those things we have to invest a lot to make sure we have the resources for it, but it is a big investment as we're going through this wave and people on board. It has been very challenging to find some of the skill sets we need, such as public health inspectors. And so it's not possible to do that. We are looking at other skill sets that can help us in supporting the response. And just to say again, and I said it at the September Board of Health meeting as well, the demands on staff are very significant. Whether it's the staff who've been doing this for a very long time and just going through the challenges of some of the outbreaks that we've dealt with, and or whether it's the staff who have come from other program areas where that's their passion, and they're giving us their very best in this particular work that they've had to learn and understand, but still yearning, I would say, for some of those other things that where they would like to contribute, especially as we see those are continuing to be issues in our community, but we just don't have the resources to do all of it. And there's also been extensive overtime required in order to do the response. And so our staff are not only just working their day job time and experiencing the burnout that would come in any case, they are very much working extended hours and working very long and hard. You'll see, perhaps if you look back at our old report, that we had actually hoped that we would be able to contain COVID-19 within that particular group. But because of the size of this particular wave and the number of connections, the number of contacts in particular, it's been very difficult for us, in fact, almost impossible for us to downsize at all the size of the group that is involved in COVID-19 response and to restart a further group of programs. And so I'll come back to that in more detail in just one moment. On the assessment center front, you'll remember that we had asked for those 17 FTEs from Ontario Health West to continue to do the booking component of the assessment center function. And we were very fortunate to work through with St. Joseph's Hospital Hamilton, who've become the lead for the assessment centers, to put in place online booking, which was a huge benefit in terms of people being able to access and book tests quickly. Although we know it was very frustrating at first because they couldn't, tests needed to be booked very far out. And sometimes they'd have to check back and check back and check back. But that in tandem with the province changing the criteria for testing to focus on those who are most likely to have COVID-19 was a very important thing in improving the demands on our staff. And so we're just at the point of negotiating with St. Joe's Healthcare Hamilton, who, as I said, is the lead agency for the assessments now, how best to move forward with the booking line, whether it whether it would do better with their staff or ours. And so we'll make those decisions as we go forward. Next slide, Steph. So in terms of our programs and services, I'll just remind you that when it comes to prioritizing our programs in any emergency response, and including this one, we go through a risk assessment and prioritize those based on the impact of prolonged discontinued service on health and safety of citizens and clients, staff safety, as well as capacity, just overall capacity to do the work, and personal protective equipment requirements that are associated with it, and then categorize them as essential, which should really be another box, or high, medium, or low. So high meaning you need action quickly in order to reduce the risk. The risk is moderate under the yellow group. And so we would resume those as soon as the control measures would allow. So this has been customized somewhat for COVID. So for some of our things we couldn't do, for example, face-to-face home visiting, it just wasn't feasible given the control measures that were in place, but we would look to resuming it. Or for example, when we didn't have some facilities up and running, then those wouldn't need inspection, for example, when they weren't running. And then finally, the lower group, which we would restart once changes to public health measures and our capacity would allow them to resume. So if you'll just flip to the next step. The essential services that are open all the time and have been open throughout the response are listed here. So they're open with some modifications. So those modifications may be that we're doing it virtually and then looking at how we could get back to doing things in person, or it may be that we're only doing some subset of the programming. And so emergency dental services is a good example where we started out just being focused in our downtown clinic where we had lots of room to have PPE on and move people in and out safely and whatnot. And then as you'll see going forward, we've been able to open up more services as we've been looking at programs and having the ability to change things so that they can operate safely. So all of these are up and running and have been throughout the response. On the next slide, these are the red programs. So we have managed to reopen all of these ones. So additional emergency treatment capacity through the dental clinics and bus. Our high-risk food premise inspections resumed, as well as our residential, some of our residential care facility inspections. Our harm reduction street health clinics and the nursing shift on the van resumed. And we began again doing vaccine cold chain inspections. We were able as well to start doing some community catch-up clinics for folks over the summer. Just hundreds would be able to be addressed through those as compared to the thousands of school students who need to be immunized, who missed their last immunizations last year. But as you'll see in a minute, we're working on those. And then our vector-borne disease program, again, around rabies in particular, and some of the high-risk services otherwise. The next one for us to reopen is further vaccine catch-up clinics for both the community grade 7-8 students. So we know if we don't get kids immunized at a particular age in terms of their emergence and their taking on of different activities as they age, that we miss a critical window to vaccinate them before those things start. And so it's very important that we get those vaccine catch-up clinics underway, and we'll be working with the schools on those as well. If you can flip over to the next one, Steph. So some of our medium risk services were able to reopen, like the moderate risk food premises, our recreational water facility inspections, small drinking water inspections. Our climate change program is back up and running, and our school program supporting the non-COVID elements of schools is back, is getting up and running, is in progress of reopening. And that is, of course, going to be largely focused around issues such as mental health and wellness in that group as well. Next slide. The next to reopen, if possible, and that's it underscored if. Those are the additional street health clinics for harm reduction, and noting that's also where we provide our flu vaccinations for these at-risk groups. So that's why they're an important one to reopen. Broader air quality work, more fixed premise and childcare inspections, the routine ones. Our principle has been if we've had to go in to do an inspection related to COVID and IPAC, as much as possible, we've tried to do the whole inspection while we're there. But there are still ones that would be outstanding. The health equity components of the food strategy, knowing that health equity is a very important issue all the time, but is being highlighted as we go through COVID-19. And then non-complaint based tobacco enforcement and tobacco cessation clinics. So those, if we are able to, and at the present time, we do not have the staff to move into doing that work, but we're looking to see as we go forward and as we get those additional resources on board and trained, it will become smoother functioning again, and we may be able to move some staff back into these programs as a priority next. And then next one. So green services, so all of our low risk ones, and these are just some of the examples like prenatal and parenting groups, the final treatment capacity under dental clinics, food safety, non-urgent complaints, disclosure postings, some of our routine inspections in residential care facilities, our non-urgent health hazards issues and reviews we are not able to do. Tobacco hotline, those sorts of things we're not able to do. So these are just some examples. There's a broader list, of course, but those are some examples of where we're at. Stefan, next slide if you can. Good, please. So that is it for the presentation. That's a lot of ground to cover, I know. Everything from Steph starting us off with what's the current status through the discussion about SpinCo from Mackenzie, and then where we're at in terms of programs and services going forward, and some of the changes in control measures that we're recommending or have recommended. So if there's any questions, Mr. Mayor, you will figure it out between Stefan, Mackenzie, and I as to who to respond, or any of the other directors who are on the line.
Okay, I'll let you decide where it needs to be channeled to. But we have a lineup of speakers. It's Councillors Farr, Whitehead, Nan, Wilson, and Ferguson in that order. So, Councillor Nan, you're first up.
Good morning. Thank you. Thank you again, Dr. Richardson, and to the remainder of staff. But yeah, go ahead, Chair. You mentioned a different lineup. And
I know. I don't know why. I think the way I saw it is different. So I think Councillor Farr is first.
Fair enough.
Councillor Whitehead, then Councillor yourself, and then Wilson and Ferguson. My apologies. Councillor Farr. I don't see Councillor Farr at the moment. Oh, I do. I can't hear you just yet.
Is that better?
That's it.
All right, thank you. My questions are for Mackenzie, and it's specific to downtown and SpinCo. Obviously, quite actively in the media a couple of weeks ago and for some time. 48 primary cases, secondary transmission. Mackenzie, you said on one slide is 26. Is secondary transmission the same as resident cases? Because on page 9 that has 26 at 46. So I'm just trying to get, I thought it was closer to 100 all told, but you have secondary transmission at 26.
Thank you. Kenzie?
Yes, I can clarify that. So there are 26 secondary cases, and those secondary cases are not SpinCo members. So it's someone who acquired the infection from a primary case. So if I was a SpinCo member and I got infected, and then I pass it on to my wife who was not a SpinCo member, she would be considered a secondary case, I would be considered a primary case. And so the actual numbers are that there are, as of Friday, there are 48 primary cases and 26 secondary cases. So 74 in total.
So what is, if we can go to page 9 then, what is the 46 resident cases?
So those are, so among our 48 primary cases, there are 46 who we consider patrons. And there's 2 that are considered staff. So under that column, I don't see the I don't have the presentation open with me right now, but those residents essentially would be our patrons.
Okay, thanks.
Does that make sense?
I understand. Yes, that does.
Okay.
Thank you very much. So really, it's around mid 70s as opposed to closer to 100, all told, emanating from SPINCO, whether a member or a close associate or family member to someone who is a member. The investigation you did, I heard today you say it's ongoing. I'm assuming that's at the provincial level. And according to yourself, the local investigation is complete. Is that correct through you, Mr. Mayor?
Elizabeth, do you want to answer that, or?
Through you, Mr. Mayor. So the investigation is ongoing. If you recall the number used by the province, they look at sort of 2 incubation periods after the beginning of an outbreak to sort of decide if everything has really changed. And so it's the same thing for this. With this one having started at the beginning of October, we're just getting through that first incubation period, and then we'll look to see beyond. And those secondary cases could still be continuing to occur. So it's not complete here. We have also worked with the province in terms of sharing the information from the standpoint of looking at whether there are more changes to the guidelines that are needed as we go forward. And so we're working with the province in that way as well. The province not directly involved with investigating this outbreak. That's left to the local level.
Oh, okay. I may have heard something. I really followed it closely, as many did in the media, and I may have heard something that made it sound like the local level aspect of the investigation is complete. We've now, because of the significance of it, passed it along to the province. That could have been just a reporting style. So that is appreciative. I appreciate that I can clear that up. I was very glad to hear actually in the media report, so maybe you can confirm this, Dr. McKenzie or Richardson, that the franchise said that they received a thumbs up from our local public health officials, that they were taking all the recommended precautions when they were open, and actually, and then some. So what did our local investigation find that prompted this involvement provincially? Is it just because of the sheer numbers? I mean, and are we sharing that information that, you know, all of the recommended precautions and then some were adhered to at SPINCO?
Thank you.
Through you, Mr. Mayor. So when we were overall looking at COVID early on, and you'll see many different iterations of this one too, there's sort of different levels of activity that are at lower, medium, or higher risk. And so overall, we know that some things where there are factors such as being close to one another, whether you wear a mask or not, whether or not you're breathing deeply and more frequently, whether you're shouting, yelling, and doing those sorts of things, whether you're indoors or outdoors, like all of those are characteristics that can increase your risk or decrease your risks. And so in a gym setting, there's a number of those that could increase your risk. So it's a higher level setting. So the province, when they went through and put in place guidelines, they took that into consideration and put those out there. However, as we started to see cases in this second wave, we saw already out of Toronto and elsewhere that they were starting to see the cases that were linked to gyms. Don't know the details of those, but had understood that from the sort of broader levels of review that were going on. So then when we had this particular incident and we went and looked at it and talked to the people and understood from those that were in the classes and involved that they were doing the things that were recommended under those guidelines, we raised back to the province to say, what have you found from your from our other colleagues across the province as you look at things more broadly in terms of gyms? Is there more we should be doing? And here's what's happened in our circumstance here in Hamilton. This is information that maybe you can consider as well. And so Dr. Yaffe did say absolutely, based on what they're seeing, they think they should refer it back to the public health measures for a review of the guidelines for gyms to see if there's more that's needed in general. And so as we've reviewed it and looked at what's going on here, we do have some interim guidance for gyms that does go beyond the current guidelines that are in place from the province, while we await the public health measure table's broader review of the evidence from all of the outbreaks.
That's your 5
Mr.
minutes,
Mayor,
Councillor. Can I put you back on?
So that was, just to close, that was referred to as the ASHRAE guidance that I heard you reference. So no shouting, no mic work, capacity of 10 people per group in a fitness room. I'm fine. I'm just glad to hear that things are looking up for the good people there on James Street North. It was concerning to see some of the social media. But I'm thankful for our public health officials working closely with SPINCO and for their responsibility throughout all this as well. Thank you.
Thank you. Councillor Whitehead.
Thank you, Mr. Mayor. Two lines of questioning. One, current information shows that the countries that we cited to justify wearing masks are having great outbreaks. Indonesia being one of them, where not only were they mandated to wear masks, but they were also asked to be in isolation and higher great degree, and it was a crime. So many of these countries now are having second wave outbreaks, and this is what we based our information on. The other, so just dovetailing on that, eyes are mucous membranes, and it's my understanding that is another way of COVID-19 entering your system, and yet we're pushing mask. The mask is the idea behind mask is to protect others from you, and sort of lower the amount of droplets that or the distance the droplets go in the air. But studies are now showing that it's clear that COVID is on a lighter droplet that penetrates the mask. And even if it doesn't go far, the problem is it stays in the air longer. So this is where my questioning is. I go into a restaurant. They cleaned out the booth, the whole bit. I sit down in the booth. I have my mask on and take it off to eat. Those droplets are still in that air if they don't have strong HVAC systems. So what are we doing on that front, since our eyes are vulnerable to COVID? We're really focused on mask, but we haven't really talked a lot about the air exchanges in internal systems that may, in fact, contribute to the spread.
Okay, thank you. Dr. Richardson.
Thanks very much. I'm going to refer this one over to Nin. He's been doing the lead on infection prevention and control along with Lachman Nandu. So Nin.
Thank you.
Thank you. Through you, Mr. Mayor. So one of the things that we are also looking into, and we've asked the province public health measures, is, and it's specific to the gym setting, of any recommendation for ventilation, that type of thing, to further reduce. We're looking at more the setting of a gym, but I imagine that whatever they find might be applicable to other settings as well. The mask is still as important, as you mentioned, Councillor Whitehead, to source control.
I appreciate that. So they did a testing on an airplane with the dummies and breathing out, some form of the virus, and measuring the effectiveness of the air exchange and issues that the air industry is in addressing this. And I think it was 97%, or very high reduction, but that evolved around the air exchange, and they use EPA filters or whatever within their systems. So I go back to the question, how do the people we're supposed to be protecting, they go into internal facilities, can appreciate the vulnerability if we don't have a good air exchange? And when are we going to start addressing the standards?
Thank you. Dr. Tran?
Yes, through you, Mr. Mayor. I think that's one of the reasons why outdoor settings are lower risk than an indoor setting. So that is one of the key findings we have. As I mentioned earlier, we are going to hope to get some additional guidance or clarification from the province in terms of a variety of factors for gyms. One of them we've asked them to look at it in terms specifically is ventilation.
Appreciate it. I'll have another line of questioning after, but that's fine for now, Mr. Mayor. Put me on in a second.
Thank you. Councillor Nat.
Thank you. Through the Mayor, thank you also again to Dr. Richardson and staff for the report. I have a few questions. One is just clarifying some of the details that are in the report, and the other is to kind of go a little bit deeper on the interim guidelines for the gyms and what else we might be able to do. So I'll try and get that done in 5 minutes. Otherwise, I'll have to come back onto the speakers list, Mr. Mayor. So in terms of the report, so if this is going to be a monthly report that the Board of Health is receiving, is there value or is there a reason not to include the geo mapping? So we recently, was it in August, that the interactive map was made available publicly? I'm just curious if there was a reason why that geo mapping isn't part of this monthly report.
Doctor?
I think it was through you, Mr. Mayor. I think it was a little earlier, actually, even than that. It might have even been back in June, but I think it may have been seen by this group a little bit after that in one of the presentations. But that's something we can definitely include if there's an interest in that. I think one of the things we always want to underscore whenever we do show those maps is that we do see it throughout the city. But absolutely, we can look at keeping that map as part of this.
I would appreciate that. And I thank you, Dr. because it just does help get a sense of the overview of the entire city from a neighborhood perspective. And if any trends do shift over time. And as a Board of Health, for us to be able to see that visually, but also then as these meetings are broadcast, for those residents who aren't online and accessing that great tool, they'd be able to see it from this forum as well. On the report slides, slide 20 and 23, RCF inspections are referenced twice. One is in coded red, and we discussed this a little bit, I believe, at GIC last week or last 2 weeks ago, in terms of the fact that we do need immediate action. I assume that this is speaking specifically about infection prevention control standards, making sure that the RCF facilities are at performing as they need to in accordance with those standards. But then in slide 23, there's indication that RCF inspections would remain on hold. So if you could please clarify.
Yes, thanks very much. As I was looking at these last night, I thought, okay, this is something I'm going to try and clarify, but we're going to need to probably do more. So, so the IRCFs have absolutely, from an IPAC perspective, we have been into those facilities, gone through them, done lots of support for them, reached out to them, continue to inspect them, and especially on a complaint basis, or if there's an outbreak, go back and do so again, as well as any other complaint ones. But Kevin, can you just speak to the routine inspections and where those are at?
Certainly, Dr. Richardson, through you, Mr. Chairman, in terms of routine inspections and working closely with our colleagues in IPAC as it concerns our routine food safety inspections, as well as our environmental health inspections. We continue to look at those in concert with the prioritization of IPAC, but certainly recognize that our ability to get out as we have in a normal period, I'll characterize it as, is very difficult. And Dr. Richardson earlier alluded to some of the staffing challenges we were experiencing prior to COVID, which have been compounded by COVID. So we certainly are aware of the need, and the focus remains to do these in tandem with IPAC, where specific premises are prioritized.
Thank you.
So just so I'm clear, then we recognize that the need is high, and as it relates to IPAC compliance inspections, then where possible and staffing is appropriate, we will tandem some of the other routine inspection components as a complaint-based inspection is taking place. Did I get that right?
Through you, Mr. Chairman, that's correct.
Thank you. A couple other questions on the report. So similarly, harm reduction services, high need. If possible, we'll get more sites. That's a big if there, I heard Dr. Richardson speak to. But at current practice, how are we doing in terms of our harm reduction services? And are we feeling a strain there in terms of capacity at all?
Thank you.
Through you, Mr. Mayor, I'll pass this one off over to Michelle.
I was ready for that one. Michelle.
Yes, thank you, Councillor. Through you, Mr. Mayor. So harm reduction, as you know, we have been strained through the pandemic for a couple of reasons. We're certainly seeing demand for the services, and some of the other agencies like ourselves have been somewhat limited in the services that can be provided. With respect to harm reduction, the van does continue to operate. That's in partnership with the AIDS Network, and they've been, fantastic in keeping that going. So that service continues. Needle exchange continues. We do have the Street Health Clinic operational again, and we are trying to, with our current staffing, we'll be able to offer flu clinics within our shelters as we do on a annual basis. And we have paramedics through Social Navigation is able to offer flu vaccine as well to some of our harm reduction clients who are not within the shelter system.
Thank you.
So although we're strained, we're going.
That is 5 minutes for you, Councillor.
Thank you. I'll come back on for the SPINCO. Thank you.
I'll put you back on. Thank you. Councillor Wilson. Not seeing her. Okay. I'm going to go to Councillor Ferguson, and we'll put Councillor Wilson on hold if she appears. Councillor Ferguson, go ahead.
Yeah, thank you, Mr. Mayor. So just a few questions. I find slides 6 and 9 very interesting. So my first question is the outbreaks from August 1st to October 16th is 77 days. And so when you say an outbreak, does that mean a positive case somewhere in the city?
Doctor?
Through you, Mr. Mayor, I'm just flipping back to those slides.
That's on slide 9.
Slide 9. So when we say outbreak, it's not a case. Unless we're dealing with a long-term care home sort of setting, that it is in that specific setting. Nina and Connie Benedict and the group actually developed a little chart for us this weekend so that we can remember exactly what the provincial criteria are for outbreaks in different settings. So because they do differ. So in long-term care homes and those sorts of settings, it is a single case that is still considered an outbreak. And I think that's because they wanted to underscore the importance of going into a full sort of response mode in case there was additional transmission there. However, usually it is both needing to have more than one case in the setting and evidence of transmission in that setting. So, for example, when we talk about schools, they could have 2 cases in the school, but it wouldn't be considered an outbreak unless we knew that somehow those 2 cases were linked together epidemiologically, or they had there was a high likelihood that they had transmitted between the 2 of them the infection. Similarly, in some of our other settings. So the specific numbers differ, but usually it requires transmission and at least 2 cases, if not in some cases 3. So.
Okay, because you do show some with only one at St. Peter's, where you explained that. That's a nursing home. And Riegel Supports for Community Living, I assume that's the same. It's some sort of a nursing home. And then when you get into schools, you see 2 and 3. What is Cushy Baby? Is that a retail outlet?
So it's actually a manufacturer here in town, and they do have, I believe they do have a retail side, but this was the manufacturing area.
Okay, and you had 3. Because it's interesting of the 77 outbreaks then that you had, 48 were at Spinkle, which is 74% of our outbreaks are at one location. And so I could see why you reacted to that by putting in new restrictions for gyms. Because it makes sense if you're at Spinkle on one of those bikes and you're going hard, you're probably breathing heavy and the sign on the door even says come in and sweat. And so there's a lot of that going on. So I guess we've learned something about this with exercise areas. Because if we didn't have those 48 cases, that would make a huge difference to the Hamilton numbers, which would explain why Dr. Harvey said on CH News this morning that the likelihood of us being pushed into advanced phase 2 now is unlikely because of Spinkle. And you see the numbers, you understand why and how that makes sense. So do you agree now that right now it doesn't appear we're heading into a phase 2 restricted or modified?
Through you, Mr. Mayor, that's always a discussion that is had between the local medical officer and the province, and is ultimately the province's decision as to what parts of the province move into that, what regions move into it. But at this point, I will note that our cases are high. You heard from Steph, I think you said 27 cases per day, which puts us well up there in terms of the number of cases, but we do have a very clear outbreak that is contributing to those cases. And the last 3 days, Steph was able to present up till Friday. I can tell you the last 3 days, our numbers have been a little lower at 15, 19, and 7. We haven't seen the full piece up today yet. Our colleagues in epidemiology are working away on it, but that is good news. So I think we're just holding, quite frankly, Councillor, in terms of where we're at. But this is part of the reason why we wanted to show what happens when you do have an increased number of cases, just how far-reaching the impacts can be and how quickly spread can occur, and why following measures all the time is so very critical.
Yeah, when I saw 7 this morning, when the CH reported that, it did a fist pump that maybe we're starting to flatten the curve again, is the old expression back in April. And so it's encouraging, and it feels more encouraging when I see that out of our outbreaks, 48 of 65 were at one location. And you're certainly given that the attention it deserves to try to reach a conclusion. That the other interesting slide, Dr. Richardson, is page number 6. And we've always said that, I've always heard that the most at risk are those over 70. And if you look at over 70 right now, the lowest percentage we have are those over 70. And so just to put the people in that category who are 70 and larger, is it generally thought that elderly are more at risk because they have some sort of other condition, be it cardiac or respiratory or, a whole slew of issues, diabetes? That's why they're at higher risk for hospitalization than anybody else. Because if I look at the 20 to 39 category, would any of those have been hospitalized? Do you have the stats on that?
Okay, that'll be your last question, Councillor. Go ahead, Dr. Richardson.
Through you, Mr. Mayor. In terms of the 20 to 39-year-old age group, we have had, Steph, I'm going to reach back since this began, somewhere around 2 to 5 hospitalizations. And I do believe, I'm turning to Steph, I do believe we have had ones in this age group, but we'd have to go back and look in particular. But certainly you're right in that the older age groups are both at higher risk because of their age, but also because they're more likely to have chronic medical conditions. As we age, unfortunately, that is the case. So both of those factors are at play.
Thank you. I'm going to go to Councillor Wilson at this point, if I don't see her still. All right, Councillor Whitehead, second time. Go ahead, sir.
Thank you. Thank you, Mr. Mayor. So I wanted to focus on, and I talked to Dr. Tran about this, and far too often I find public health, which rightly it's a triage, you deal with the crisis in hand. There appears to be another crisis breaking, and we're not bringing those numbers forward to the full extent. What's the impact it's having on the community in the context of the mental health, addiction, suicide, all those other, and it seems to me that even when I'm following what's happening in the States, public health is very resident in bringing those numbers forward. I don't know why. So help me understand what is the thought process and not understanding some of the decisions we're making and the broader implications it has in our community. For example, in our health system, how many people are going to the doctor, are avoiding doctors now, avoiding going into the hospital because they're concerned about coming down with COVID.
Okay, Dr. Richardson.
Through you, Mr. Mayor. The whole issue of mental health is very much on our mind, and it's on the mind of all of our health system partners as we're going forward. I can tell you it's on the minds of all of the public health professionals across the province. It's definitely something that we talk about on a regular basis and talk about the impacts of this and the control measures that are put in place in terms of mental health, as well as the broader impacts in terms of economy and prosperity of our local businesses and just the impacts that all of those things have as well. And so you'll see more on the social determinants in the next presentation that we do. I can tell you from the standpoint of mental health, we do track these things regularly. We can't say specifically that the COVID was the thing that led to these particular impacts, but we do look at emerge department visits for overdoses. We look at it for mental health reasons. We look at a variety of indicators that Stephanie and Mackenzie and their colleagues put together for us actually every week, in the Hamilton COVID response table reviews those each week as we go forward. We are hampered by the data that we have to use, and so in some cases the information sources just aren't there, and or it's not able to be refreshed on a frequent basis to make it really represent what's going on today versus things that we'll end up measuring further down the line. But absolutely, it's for those reasons around things like mental health that we're talking about schools and the importance of balancing risks between COVID-19 and the other things that are both out there in the community and that are worsened perhaps by the control measures that are put in place. This is why we talk about kids and the importance of going back to school and why they need to be in the school environment. Yes, there's some risk of transmission of COVID-19, but from their overall assessment in terms of their development, their academic performance, their mental health, it's better that they are there in the schools and able to learn in that environment and with those supports. So you'll have seen as well from us as we go forward, we have had some worrying trends, for example, around overdoses. And so we put out an alert last week about what we had seen, what we had heard from the qualitative information that we collect from our partners around some of what they're seeing in terms of the drug that might be being used and might be doing it. So absolutely, mental health is something that's on our minds as we go forward. We've talked about it in terms of our programming and why we're still following those priorities of mental health and addictions, health equity, healthy weights are still priority areas for us as we go forward, and we're trying to do as much as we can through the ADGS program, the Child and Adolescent Services program, as much as we can in harm reduction, while still trying to do the COVID response. So if it's helpful to bring a report that gives a little bit more of an overview of that data, perhaps something we could do either for December or the beginning of next year.
Thank you.
I noticed you didn't talk about sides. Is that a reason?
Sorry, I missed that.
I asked about suicide. So what you talk about mental health and some of the concerning issues about overdoses and so forth, but overall, is there a trend going on suicides?
Through you, Mr. Mayor. So I'm not trying to avoid any particular issue because there is something there that is not happening. I'll just turn to Steph, and she does a lot of this work with us over the weeks, and just I'm not remembering the specific stats. I can tell you that we haven't seen anything that's worrisome because Steph flags those to us. But Steph, anything you want to add in terms of the monitoring that you're doing around those?
Thank you, Steph.
So through you, Mr. Mayor. So as Dr. Richardson just mentioned, we have been monitoring what we're calling vulnerable populations for quite some time, so for a number of months. We're performing surveillance on more of the mental health related side of things. So we've been looking at mental health related emergency department visits and opioid related emergency department visits, things like that, just to see what other concerning things might be happening out in the community. And we have not seen any concerning patterns, anything worth flagging yet. Nothing really has been spiking and worth flagging as of yet. However, we have been monitoring these in case we do see anything and requires immediate action.
Thank you. Councillor Redditt, that's 5 minutes for you.
That's very comforting. And the only reason why I raise it, because I'm on a mental health chat group. And what I'm finding is a lot of people are saying that they're having a lot of what they call panic attacks for the first time. So it concerns me that they're experiencing something they didn't experience before. So I just wanted to highlight that. Thank you.
I think there's no question that level of anxiety in the community at large is high, and certainly that would amplify, concerns around mental health issues for those that have them. So I don't think there's any doubt that is an unfortunate byproduct of where we are today. Thank you, Councillor. I've got Councillor Clark for a first time. Councillor Clark.
Thank you, Mr. Mayor. Can you hear me okay?
Yes, sir.
Thank you. So when this illness first hit us, we were advised that it would impact seniors and those with chronic diseases more. And then this second wave seems to be hitting, and it seems to be a different age group, at least from what I'm seeing. So are we more concerned now about, the 20 to 40 group getting this illness, or why this change has happened?
Dr. Richardson.
Through you, Mr. Mayor. So when we talk about impacting a group more, we use different kinds of measures to measure impact. And so strict case numbers are one way of measuring impact, how many people get sick at all. And then we look at how sick did they get, the morbidity and mortality that's associated with them getting that illness. So still, we're most concerned about seniors, those with chronic medical conditions, in terms of them having a higher risk of getting very sick with this, ending up in hospital, ending up in ICU, and potentially dying from it. However, we are seeing that in our trends, and we've seen this early on, it had kind of come down a little bit and now is back up again in that 20 to 29 and 30 to 39 year age group. There is more socialization. There is more people getting the illness, although they don't get as sick which is what we've seen in the epidemiology overall. They don't get as sick as those who get the disease when they're older. And so that's where, with Steph continuing to present those 4 waves of illness and seeing how we had so many outbreaks in long-term care and so many, that's where the majority of our deaths did occur, as well as deaths that happened in community dwelling elderly. But in this particular phase, when it's in this younger age group so far, we don't see the number of hospitalizations and deaths. However, I will say, and Steph reminds us of this regularly, that it isn't limited to those age groups. And as you can see, we have seen extension into family members, others who are in those older age groups in the 50 to 59 age group, and as well just some primary infections that have happened there. With people going out again, socializing, travel, those sorts of things. So very much we remain concerned about protecting those who are most vulnerable, and hence the very strong recommendations still around long-term care. That's why they're still doing universal masking in long-term care. We're trying very hard to ensure that they remain protected while, again, remembering the issues around quality of life as well for those populations.
Thank you.
So to paraphrase, while the younger groups may be experiencing an increase in infections, the risk is still with seniors and those with chronic disease or immunocompromised individuals, correct?
Through you, Mr. Mayor, yes, in terms of a population spectrum, that's not to say that we haven't had younger people get very ill.
Yes.
But, that still does happen, but the likelihood of that happening is lower in a younger person than an older person.
So when we're talking about chronic diseases, I would assume chronic obstructive pulmonary disease, heart disease, diabetes, people being treated for cancer, or people with biologics for chronic diseases such as arthritis, multiple sclerosis, et cetera, those are the types of chronic conditions that we're talking about. Is that correct?
Through you, Mr. Mayor, yes, the list is fairly long, but and goes on renal disease and others, but yes.
Okay, so we continue to caution people who have those chronic conditions to be very careful then, correct?
That's correct.
Thank you. I appreciate that.
Thank you. First time is Councillor Wilson. I don't see Councillor Wilson at the moment, so second time, Councillor Knott.
Thank you. Through the Mayor, just following up on the gym guidelines and the interim guidelines around capacity limits, physical distancing measures, and recommending masks. Just thinking about the severity of the outbreak and how we can, as a Board of Health, support not only those interim guidelines, but also prevent such an occurrence taking place again. I was wondering if I could, through you, get comment from staff about where our current mask bylaw stands as it relates to fitness facilities.
Through you, Mr. Mayor, perhaps I'll turn it over to Nin to talk about the masking bylaw.
Thank you.
Thank you. Through you, Mr. Mayor. So in terms of gyms, the masking bylaw applies throughout the gym until you're engaged in physical activity or working out. So there's a specific exemption in the bylaw as it stands that isn't required if you're engaged in active physical activity. But prior to that and after that, the bylaw would still apply. So if you're entering the gym, you're registering, you're in the locker room, you're expected to wear the mask, but there is a current exemption during physical activity.
Through you back to Dr. Nin, if you could comment on that difference. So previously, when we were discussing the mask bylaw, it was thought that wearing the mask during physical activity could impair other or cause other kinds of health concerns or get in the way of getting enough oxygen while you're physically active. At this point, and given the outbreak in the facility recently at Spinco, would removing that exemption in the bylaw be recommended from a public health perspective?
Through you, Mr. Mayor, yes, it would be recommended. At this time, it was, after careful consideration and seeing what's happened in our gyms, as well as some others, that where we are now recommending the use of a mask even with physical activity in a gym to prevent what's happening, and we would be supportive of removing that exemption.
Okay, through you then, Mr. Mayor, if it's appropriate, I'm not sure if moving it at Board of Health is the right forum or if it needs to be at another one, but I wonder if this is the recommendation coming forward from Public Health at this time, that the exemption needs to be updated in our bylaw. Would it be appropriate to move that motion or recommendation here at the Board of Health today? Mr. Mayor, your microphone isn't on.
Thank you. That was my fault. No, I would say not at Board of Health, but certainly at GIC. And I think if Public Health or Dr. Richardson's prepared to recommend that change. I heard it as a recommendation first, but didn't necessarily hear it was going to be a change to the bylaw. But I think totally appropriate given where we are. So, Dr. Richardson, something you're prepared to recommend that we change the bylaw?
Through you, Mr. Mayor, or to the point, we are recommending that masks be used. I think the reason why we hadn't full out recommended a change to the bylaw initially was that it is interim guidance and we're waiting for the province, and I'm not sure if there's going to be any nuances or anything associated with those that would necessitate amending the bylaw again. But certainly we could go ahead, amend the bylaw, and then make any further adjustments as any new information comes from the province.
Okay, thank you. Councillor,
Yeah, that's it.
Ned?
Yeah, no, that
okay.
provides the clarity. Thank you.
Yeah. Second time, Councillor Whitehead. Oh, yes, that's true. That's third time for you saying it. Hang on a second. Councillor Clark, second time, and then Councillor. Go ahead, Councillor Clark.
Thank you, Mr. Mayor. So can I ask, I also heard that there were interim guidelines to the gyms that they had moved the spacing from 2 meters to 3 meters. So I'm trying to assess, that's going to be redundant. I'm trying to understand how public health is assessing what the risk is in the gyms and how do we know that the aerosol of someone's breathing because they're exercising aggressively is not spreading beyond 3 meters. I'm told that in a gym setting, it almost becomes airborne because they're breathing so hard. So how do we know how far it is spreading?
Through you, Mr. Mayor. So we've had those discussions with the province around what they're seeing in terms of looking at the evidence and what they've looked at in other jurisdictions. And that is part of the discussion that is ongoing at the public health measures table to look at, just how far might it be. But in terms of what we've seen in this outbreak and what we've seen from our colleagues in Alberta, where they have introduced a restriction of 3 meter distancing in these situations, we think it's important at this point, while the broader discussion and review goes on, to at least take it out to that point, as well as reduce the number of people in the class. And if they can't, do that 3 meters distancing, there would be even less people in the class. So that's why it's an interim based on what we know now, and then looking to expand that or revise it based on what we see as the public health measures table does their broader review.
Thank you.
So it's basically a precautionary principle at this point until we understand exactly what that review is from the province. So do we have any assessment on the breathing through these masks in a gym setting where they're doing heavy exercise? Is there any risk to lowering your oxygen level because of the mask getting wet or whatever the case is?
Through you, Mr. Mayor, when it comes to masks, the kinds of masks that we're talking about shouldn't lead to that sort of challenge in relation to them. The N95 masks are a whole different ballgame when it comes to those, but particularly in these sorts of settings. And if anybody's not able, finds that wearing that mask is difficult for them in terms of exercising, or the mask isn't able to stay dry, it becomes so that it's not really functioning, then we would suggest that they don't participate in that activity because it's a situation where, again, we're trying to balance those risks. And so, take the activity outside. There are many ways you can reduce your risks and still exercise at a high level. It may not be the exercise of choice, but they could go and choose to do something different where they could still reap the benefits of exercise without having the possible risks associated with it.
Thank you. And so did I hear you correctly, Dr. Richardson, that there are N95 masks that are being used in the gym settings?
No, through you, Mr. Mayor, my apologies. I do tend to muddy the waters sometimes when I bring an example such as that. No, I was just saying that these are not that sort of mask. It is with N95s that we really do see those challenges around the ability to get in. It takes a lot more effort. They're a lot more demanding to breathe through. We're not talking about a mask of that sort. We're still talking about the non-medical
surgical
masks.
Yes,
Yeah.
thank you very much. I appreciate that. Thank you.
Great, thank you. First time, Councillor Wilson.
I'm going to, if you could go on to someone else, Mr. Mayor, I just rejoined, so I don't want to ask a redundant question.
I appreciate that. Thank you. Okay, I will. Councillor Ferguson, second time.
Yeah, thank you. I just want to finish up on my last question I was doing to Dr. Richardson. We talked about that age group over 70 and that Councillor Clark's question helped answer some of my question, but they're still a high risk, particularly if they have chronic diseases. There's a lot of people in our community that have chronic diseases, and there's really two categories. There's been diagnosed with something like diabetes and those that have complications from it. If you have no complications, in heart disease, kidney disease, foot sores, if you have no complications and your A1Cs are below 7, are you at the same risk just because you're diabetic as you are with those with complications?
Through you, Mr. Mayor, it's certainly the more complications, the more chronic conditions ultimately you have, the higher risk that you would be at. I don't think we know yet to say, at what point does the risk disappear in relation to that. I see in the sort of emerging science pieces that come across my desk, little studies that have been done on those things, but I don't think we know as a whole well enough yet to say at this point you're okay. You don't have that much elevated risk or any elevated risk, and at others you have higher. They would be sort of broader recommendations if you have those conditions.
So if you're simply diagnosed with a chronic disease, assume you're at higher risk.
Essentially, through you, Mr. Mayor, depending on exactly what the disease is. So, for example, if you actually have some sort of ligament issue that is an ongoing challenge for you, that wouldn't put you at higher risk. But if you had something that was a chronic disease, such as the ones Councillor Clark was mentioning earlier, it would.
Okay, that's all. Thanks.
Thank you. There is a listing available of pre-existing conditions that I believe, Doctor, isn't there?
Through you, Mr. Mayor, I've seen them amended a few times. Dr. Harvey, do you have anything to add on that front?
Just to suggest that it exists. Not asking you to read off the list. I'm just saying that there is a list that exists that can be shared with folks if they want to share it with others for their information.
Yeah, I think anybody that has any kind of general medical condition that's ongoing, that's essentially posing a challenge to them, even if it's well controlled, COVID-19 infection is just another battle that they have to fight, and they'll be less able to fight it. The changing list is just that. It's a changing list. As Dr. Richardson referred to, we're getting more information all the time. So I think that's the best caution is if you have any kind of a chronic illness, this is not an infection that you want to kind of add on to having to deal with.
Okay, thank you. I'm going to turn to first-time speaker, Councillor Pauls. You just unmuted yourself. There we go. You're back.
Thank you. Dr. Richardson, we always do a report on positive cases. Is it beneficial to say how many of those positive cases ended up in the hospitals? Because I know there was one question asked, how many young people were in the hospital, and you said maybe 1, maybe 5. Is it beneficial for us to do positive cases, and how many of those positive cases were in hospitals?
Doctor?
Through you, Mr. Mayor. Yes, absolutely, because the number that are in hospital or who are in ICU is important to see. And so Steph has given you some indication of that as she's gone through and discussed it in terms of hospitalizations. And indeed, for this last set of waves, so if you go back to that chart that had the 4 waves, you can see the number of hospitalizations, number of deaths in each wave. And you can see that lately they are down definitely compared to earlier. In large part because we're dealing with cases that are in this younger age group, which is a good thing. So if there are improvements we can make in terms of the way we present it, but yes, absolutely, we're trying to show that as we go through in each case.
We see it, but I'm just wondering the public. I know a lot of people says, "Oh, it's really terrible. We have so many," and we do. It is, you know, it's reality right now. But I always say, yes, but you know, how many were hospitalized? And they say, "Oh, yeah, but everybody's getting it." I think we need to be clear. They were positives, and also in the media say how many were seriously in the hospital, and so. I think it's important for everybody to know that as well. But my other question is about the masks. I find people, they think they have the mask so they're protected from everything. I have the mask, and sometimes maybe even if they have a cold, they'll go out or they don't feel well. So it's a false security kind of sense. Can you repeat how important it is? Even if you have a mask and if you're sick, you should stay home. Can you repeat that, please?
Through you, Mr. Mayor, absolutely, and thanks for the opportunity to do so, Councillor Pauls. I think this is one of the challenges we definitely did see when masks first started getting used. Was people started to think, if I have the mask, I don't need to worry about the other things, and that's not the case at all. If you have the mask, that is one of a hierarchy of controls that are used in order to reduce the likelihood of getting sick or spreading the illness, particularly in case of the mask. So, physical distancing is still very important to do, even when you have a mask on. You should really only be letting people into that closer zone of 6 feet, the people who are in your immediate household, and not others. The hand washing remains very important. All of those public health measures are important. And the one that you mentioned about if you're not feeling well, if you're feeling sick, do not go out. Please do not go out. Please stay home. The mask is part of source control, but the reason why it's there is actually for those days before you know you're sick. And so once you know that you're sick, then you really do need to stay home, because that mask isn't fully protective the way that it would be if you were using a healthcare system sort of mask. So staying home is very important to do if you're sick in any way, shape, or form.
Thank you for clarifying that. Thank you.
Thank you. We continue on with our media briefings and community briefings actually today and on Thursday, now weekly. We've actually stepped it up so that we can continue to get the messaging out there. Certainly no one's immune. If you're wearing a mask, you're putting in a measure of protection, but if you're sick, stay home as much as you can. Going to second time, Councillor Whitehead. Third time.
Zero blood types are registering a high percentage in certain blood types. Just comment on that. Second piece is mask. As I understand it, the biggest risk in mask is every time you interchange with taking it off and on and then passing on to your hands. So we have to remind the public, if they can get even the little hand cleansers every time they handle their mask, after they put it back on, they should be probably cleaning their hands, because that's the risk part when they're handling the mask. And the last piece is the flu, because we're expecting this is the flu season. We got COVID. What is our flu counts? How is that clouding the issue of COVID?
Thank you, Dr. Richardson.
Through you, Mr. Mayor, very important what you're saying about washing your hands or using sanitizer after handling your masks, absolutely, and washing them after each time that you've used them as well. And for flu, I'm glad to say that so far we don't see much. And indeed, that's another piece of what Steph and her colleagues are monitoring daily as we go forward, or whether or not we are having any cases of influenza. And as well, getting the flu shot campaign out there. It is officially launched, I believe, as of today by the province, although we do know that the pharmacies and family doctors have already had it on hand in order to immunize those again who are most at risk, those with chronic diseases and the like. And then there'll continue to be flu shots available through the coming weeks as more shipments come in. So flu is a very important issue. We have started to see some other respiratory outbreaks, though. We have had at least one that was not COVID. I don't believe we ever did find an actual virus that underpinned it. But it absolutely is something that we both know can overwhelm the health system as well. It has done year over year, but further will cause challenges and be this issue of trying to sort out what's flu, what's COVID as we go forward. So that's part of the reason why the flu shot campaign slogan is about it being more important than ever.
Thank you.
Thank you. All right, thank you. And I see no further speakers at this point. So a motion, Councillor Pearson? Sorry?
Thank you. Sorry, Mr.
Councillor
Mayor.
Pearson waving as well. Yeah.
Well, I did
Councillor
request it
Pearson.
on the computer. Thank you.
Okay, didn't see it.
And just wanted to touch on Dr. Richardson. Thank you for your comment about the flu shots. And I know I sent an email last week, and I thank you for your response. So you could just elaborate for the public, because I got several calls from residents who were very concerned that the pharmacies did not have a supply of the flu vaccines. But we do not control that. So can you just explain that parameter? And I understand one resident advised that their physicians are not allowed to give them flu shots now. Is that correct?
Through you, Mr. Mayor. So it is a bit complicated in that way, but the flu shots do come out over time. So the province receives in shipments and they send shipments out over time. So it doesn't all come in sort of for September 1st or anything like that. And the province, of course, prioritizes the vaccine so that it can get to those who are at highest risk first. And they ship it out directly to pharmacies, and then it goes out to family doctors and the like through us. And so we don't know exactly when and where the pharmacies are getting their shipments, but roughly we're all getting an early shipment, and we're getting that out so that people who are at high risk can get it, and then it will continue to roll out as we go forward. So in terms of the family doctors being able to give it, part of the challenge is around the fact that now when you're having an interaction with somebody that's that close, the healthcare provider needs to have PPE. And so different family physicians have been able to set up different ways of doing it. So some of them are able to do it, but certainly if you can call through to your family physician, call through to the local pharmacy who you use, you can figure out which of those might work best for you. There will still be lots of different places that will have it on hand, but it will roll out over the coming weeks.
Okay, thank you for that clarification. Appreciate it. Thank you, Mr. Mayor.
Okay, thank you. So we've had a good update, and I did a motion to receive the update report, moved by Pearson, seconded by Councillor Clark. Thank you. And in favor, please record your vote. For those that can't vote, please give me your manual signal. Councillor Clark, thumbs up. Anyone else need to do that? Councillor Marula, thumbs up. Councillor Wilson, Councillor Farr, thumbs up. Councillor Collins, not
I
sure.
support. Yep, thank you.
Yeah. Yep. That's carried, thank you. And we're going to move on to item 9.2, which is the social determinants of health. Dr. Richardson, once again.
Thank you, Mr. Mayor. So this is the first full report that you have on our analysis of the social determinants of health data that we have collected since May of this year. So just bringing us back through that timeline where we started to talk about the differential impact of COVID-19 on different segments of our community. And there was a couple of health units who led the way in terms of devising some questionnaires that could be used for collecting the data and understanding it's very sensitive data as well. And this is sort of new territory for us in doing things this way. The province had indicated that they were going to look at getting a standardized questionnaire, which we waited for, but since it wasn't coming, we adapted what our colleagues had done and began collecting that information in May. As well, we then decided to go back and look at the cases that would agree to collecting the information in retrospect as well. So there's been a big effort by our staff to very tactfully and appropriately collect this information from cases who were willing to provide it. Mackenzie's going to talk more about what we saw and what we went through, and acknowledging that this is that what we're able to give is representative of those who did choose to respond. That, of course, being their choice. I'm not going to speak to the outcomes of it, but just maybe give that intro to it as he pulls it up. And just a reminder as well, this is the analysis up until August, and then we continue to collect the data as we go forward. So Mackenzie, over to you.
Thank you. Thank you, Dr. Richardson. I hope everyone can see my screen and hear me okay. If there are any issues, please let me know. So as I introduced myself previously, I'm Mackenzie Sleepers. I'm one of the epidemiologists for Hamilton Public Health, and I was supporting the analysis of this data that we had collected for the social determinants of COVID-19. So Dr. Richardson did go over some of the purpose and background already, but just to reiterate, this presentation will focus on the status of the COVID-19 cases in terms of their social determinants. And when we are referring to social determinants, we are referring to the health conditions that impact where people are or related to where people are born, grow, work, live, or age. And so some of the key ones that you may be familiar with are things like income or your occupation, where you live. And so we'll go over some of those in a few minutes. So Public Health Services did begin collecting the social determinant of health data in May of 2020. And so not only did we start there and collect the data moving forward, but as Dr. Richardson had mentioned, we also went backwards in time, looking at our previous cases all the way back to March to also re-interview and recollect that data to get a better sense of our overall picture in terms of the social determinants of health for all of our cases. So following our implementation of actually collecting this data in May, the province came out with this as a data collection activity as well in June. So the methods and analysis, very briefly, we looked at all of our cases between March and August of 2020. And in total, between that time period, we had 992 reported COVID-19 cases that we used for this analysis. So in total, we had 992 cases during that time period. And of those 992 cases, we were actually able to get responses from 630 of those cases in terms of collecting information on the social determinants of health. So that gave us a response rate of about 64%. So 64% of our total COVID cases during this time actually provided an answer to these social determinant of health questions. I do want to flag though that no data set is perfect, and so there are some limitations. And some of those limitations include that this data is based on those who were tested. So we know that not every single COVID case in our community is actually captured in our surveillance data. Not everyone goes to get tested. Some people don't seek that out. And so these are really focused on those who tested positive and that we have a record of. And that there also is some low response rate from some of our groups. So although overall we had a 64% response rate, this did differ by question. So one example is that we did have a quite lower response rate for the income question. So people were less willing to provide their income. So the results that we're going to look at include these social determinants of health. So race, visible minority status, Indigenous status, language, household size, income, employment or occupation, and sex. So these were the social determinants that were measured. And in order to compare or have some type of reference, we use the 2016 Hamilton census as a comparison. But please note that you'll see that throughout some of the slides, and that the census is from 2016, so it is nearly 5 years old. The responses to these different categories were collected based on self-identification. So when we asked these questions to our respondents, they were the ones who self-identified what race they were, what language they spoke, their household size, their income, employment as well. And it's important to know that these measures are not necessarily consistent over time, and they can follow into patterns similar to those patterns that we saw in Steph's presentation around different waves or phases. So we're going to move on to the findings. So our first finding is looking at race and visible minority status. So reported COVID-19 cases were more likely to self-identify as a visible minority compared to the Hamilton population. And we can see that in figure 1. So in figure 1 here, we see that just over 50% of our COVID-19 cases identified as a visible minority. According to Hamilton's census from 2016, about 19% of our general population identified as a visible minority. So you can see that there is a disparity here in terms of more of our COVID cases are identifying as a visible minority than what we see in our general population. We find the inverse for people who identify as white, where just under 50% of our COVID cases identify as white, but in our general population for the city of Hamilton, 81% of our population identifies as white. So we see fewer of our cases in this demographic. So there is that disparity that exists there. And if we were to break down our visible minority population based on these more specific but still broad categories of what race they identify as, we can see here that the number one race is people who identify as Black at 14%. Which makes up a considerable section of our visible minority group. And then we can also see that East or Southeast Asian makes up the second highest bulk of our visible minority group as well. It's important to point out that although 14% of our cases may identify as Black, within our community, about 4% of our community identifies as Black. And so there is a disproportionate impact of COVID-19 on the community that identifies as Black. If we look at Indigenous status, we see that 1.9% of our COVID cases identify as Indigenous, and this compares to about 2.3% of our total Hamilton population that identifies as Indigenous according to our 2016 census. If we look at the findings from language, almost all, so 95% of our COVID cases are comfortable with speaking an official language, which includes English, French, or both English and French. If we look at household size, we find that 84% of our cases are from households of 5 or fewer people. And you can actually see in figure 3 here, the bar graph, the percent of our cases according to the household size that they come from. And so you can see how that is distributed. We also found that our average household size was larger for visible minority cases compared to cases who identified as white. And so that has been out in the literature and hypothesized to perhaps be one of the components around why there might be some disproportionate activity of COVID in our visible minority population. Moving on to the results for income. So our reported COVID-19 cases were more likely to live in low-income households compared to the Hamilton's general population. And we can see that in figure 4 here on the left. So for our COVID-19 cases, 27% live in low-income households. Compared to our city comparison, which again is a 2016 census, we find that just under 19% of our general population lives in low-income households. So you can see that low-income households are disproportionately represented in our COVID-19 cases, similar to the findings for our visible minority group. The next graph, figure 5, shows the percent of our population that lives in low income based on those who identify as visible minority or those who identify as white. And so our visible minority cases were 3 times more likely to live in low-income households compared to our COVID cases who identified as white. Moving on to employment and occupation, we found that most of our COVID cases, so 63%, were employed, 6% of our cases were unemployed, and 31% of our cases were actually not participating in the labor force. So those would be people who perhaps are retired or identify as a homemaker. And in the bar chart, you can see here in figure 6, the percent in each of these different groups broken down a little bit further. And so actually, if we do calculate what the unemployment rate is for our COVID-19 cases here, it doesn't differ significantly from our overall unemployment rate. Another significant finding is that 20%, so 1 in 5 of our COVID-19 cases were actually healthcare workers. So a considerable proportion of our COVID cases are actually people who are working in the healthcare field. Moving on to our last result around sex. So there are more female COVID cases that we've had reported to us than male COVID cases in the city of Hamilton. And when we actually do a deeper dive into that, we see that it's largely driven by that gender difference in the healthcare worker occupation. So as I had mentioned on the previous slide, 1 in 5 of our COVID cases is a healthcare worker. And when we look at our healthcare workers, 80% are female. And so when we look at our non-healthcare worker population, so if we look at our COVID cases who do not work in the healthcare field, there is more equal distribution among the genders. So it's more closer to that 50-50 split of male and female. Our male cases were also more likely to be hospitalized and more likely to die when infected with COVID-19. And so you can see that here in figure 7, we have our female seniors on the left and our male seniors on the right. And so 40% of our female seniors were actually, of our female senior cases, were actually hospitalized, and 13% of those cases were fatal. 50% of our male senior cases were hospitalized, and then nearly 22% of those cases were fatal. And this finding is not surprising. It is very consistent with what we have observed in the research literature. So the key messages, COVID-19 has highlighted pre-existing inequities, racialized populations, healthcare workers, and people living in low income have been disproportionately impacted by COVID-19 in Hamilton. We also found that males and seniors were more likely to be hospitalized and die when infected with COVID-19. And again, these findings are not unique to Hamilton. They do align with other communities. So the results that are coming out of Toronto, Ottawa, and Waterloo, for example, and they also tend to align with what we are seeing published in the research as well. So at this point, I'm going to turn it over to Dr. Richardson to take you through some of the actions.
Thanks very much, Mackenzie. So you'll recall that you've had presentations earlier in terms of what we've been doing from the standpoint of equity and addressing issues to improve health equity. If we had not found what you have just seen presented by Mackenzie, people who had COVID-19 who didn't have more challenges from a social determinants perspective would have had challenges in any case that were greater than those without those social determinants of health challenges. So for example, if somebody was had a case or was a contact of COVID-19 and had to isolate, those who don't have the income or the connection to be able to order in food or have somebody go and pick up food for them so that they can have that healthy food supply, they would be more affected than the individual who has income or connections in order to do that for them. And so there have been actions that have been taken since the beginning through the city's EOC and through public health specifically to address the impacts, the unequal impacts that COVID-19 would have on people in our community. But certainly as well, it's been important to look at the details, to have the information that's specific to our community to understand how exactly the determinants of health are impacting people differently, or sorry, COVID is impacting people differently across our community as well, and then to be able to further tailor as needed. So you'll see here the list of actions that were begun quite early on in the pandemic, everything from collecting and analyzing data, which is what we began in May, but making sure to support our shelters to follow public health measures, delivery of essential supplies such as medicine, food, those sorts of things to people who don't have other social supports. We've done work with our Indigenous organizations to support them in their COVID response. We've done enhanced infection control support in a number of congregate settings, particularly in residential care facilities and temporary farm worker housing. As well, we've done COVID-19 mobile testing, thanks to our colleagues in HamSmart, as well as our own public health nurses and in testing those who live in shelters. We've done mobile testing for those who are isolated and unable to get to an assessment center, thanks to our colleagues in paramedics, and as well helping people to access mental health and addiction supports as they go forward. So next slide, Mackenzie, if you would. So we're going to continue as we go forward to do all of those things that you've just heard about. We are working with our mental health partners. If they are sitting at the table, that Hamilton COVID response table that you saw earlier, working with them in terms of the programming that's needed. You heard us talk about schools and mental health, and as our school nurses come back online, we anticipate that's going to be a large area of focus for them. We'll also be working with the Hamilton Health team. Mental health and addictions is absolutely a focus for them as well, and they're working on those issues as well. We're going to be continuing to make sure that our social service providers who work with vulnerable positions know when and how to access testing. You'll recall that we've maintained that for those who are unable to book online or have access issues, they can continue to call us and we'll arrange with them either a testing appointment that they can get to or a way, as I said, with our paramedics colleagues for mobile testing so that they can get tested. We are working with our congregate settings. We're more and more encouraging, and the province has been encouraging congregate settings to do that self-review around IPAC, and then we support them in that. And if there are any concerns, of course, we help them in terms of following up, but would follow up if they were unable to move forward as well. There's been advocacy by this Board of Health around basic income principles, which you might recall from the last Board of Health meeting. And then we're also working, as was pointed out earlier, to mitigate the unintended consequences of control measures. And that's everything from the mental health work that we've been talking about earlier, but also the issues of deferred immunization, dental and vision health care, and loss of income on those fronts too. Next slide. There's been advocacy for protecting public policy to protect seniors and low-wage frontline workers. And some of that was even in the letter that you endorsed today around what's happening in long-term care homes and the need for appropriate supports and structure and whatnot for those working in long-term care, who are the healthcare workers that Mackenzie was talking about earlier. Adequate human resources to support vulnerable populations. So we know there have been challenges in terms of the number of people on hand, and in fact, we hear regularly that health human resources are the #1 issue that's really facing us in the COVID response right now in terms of just having the number of people available to provide support and care, and we experience this in public health as well to undertake the response. Collaborating with communities who are disproportionately impacted by COVID-19, including racialized and low-income communities. And so you've heard about the work we're doing directly with the Indigenous community as an example, but looking to work with others as we go forward. And working as well, of course, with any of the service provider organizations that support those organizations. And then the other piece has been, and you've seen this as a theme, you've seen now, Toronto has established a voluntary isolation center to minimize household transmission. So this is a place where people can go if they are COVID-19 positive in order to isolate away from their family. And you saw Mackenzie talk about the number of people who are in households. And we know that household transmission is a significant way that this gets transmitted. So they could move away, be outside of their household until they've gone through their illness and then go back and not be continuing to expose their family members. So those are the things that we're working on in relation to this. And I'll turn it back to you, Mr. Mayor.
Thank you very much. And we have some questions from Councillors Wilson, Nan, and Whitehead. Councillor Wilson, go ahead.
Thank you, Mr. Mayor, and thank you, Dr. Richardson and your team. Just a few questions, please. Looking forward at the time when we have a vaccine, will we be actively monitoring the demographics of who is getting vaccinated to make sure that the groups that are disproportionately affected are the ones receiving the vaccines?
Through you, Mr. Mayor. I think that the piece about the whole vaccination piece is something we think about not only for COVID-19, but it's something that we do regularly as we're, carrying out all of our immunization programs. So we know, from those programs that those schools that have more challenges from a social determinants perspective have a harder time in terms of their immunization rates. And so we do work with them. As you've seen, we've now introduced high school clinics so that, in our other years, so that they could more easily catch up by being on site. And we've looked at other ways to continue to do so. We do with our immunization program for flu. We offer it, as you saw earlier, through our street health clinics. So it is one of the reasons why we'd like to get more of those up and running. So it's something we think about each day, and we'll absolutely be thinking about it as we go forward with any COVID vaccine if and when it becomes available.
Just a supplementary, if you don't mind, Dr. Richardson, so I understand what you said. You talked about some of the delicacy, if you will, of collecting some demographic data, but will we in fact be collecting demographic data when it comes to the vaccination practice? I wasn't sure I understood your answer.
Sure. Through you, Mr. Mayor. So when it comes to administering the vaccine, we don't know right now who's going to administer it exactly. Will it be public health? Will it be primary care? Who might it be? And so we'll have to look at that piece around data collection and distribution as it goes forward. But absolutely, we'll be looking more so on the delivery side to make sure that we're making it available to people who are more challenged on the social determinants. And then we will also look at what we can do in terms of analyzing that as we go forward to see how it impacts. So we'll be dependent on, if it's delivered through primary care, some of them are able to look at their data and make more of an assessment. They may have started collecting things like income and those sorts of things, but we'll have to work that out as we go forward in terms of analyzing it after the fact. But certainly when we're looking at how we can roll it out, that will be taken into consideration.
Okay. Is there what's the word, epidemiological and ethical argument for the distribution, for example, of the vaccine to those most at risk? So this report is telling us who is at risk, who is getting hit hardest in terms of the proportionate, and therefore should this be informing our plan of how we're going to and who we're going to vaccinate first?
Through you, Mr. Mayor, absolutely. There's, I would say there's both of those imperatives around what we do going forward. And so we would definitely be including those sorts of factors in the design of the plan as we go forward about how can we get out to those that are at highest risk. That means both by social determinants, but also from a health status perspective, and then how we could ensure that they're able to both access the vaccine and any other supports they need.
Thank you.
And I apologize if this came up during the discussion during your COVID report. But you referenced the one indicator that you had some difficulty getting in the respondents was that of income. And so I'm wondering, in terms of our city, which has in code red conditions where we have such a discrepancy of health, were we able to measure their place of residence, and how, with our discrepancy in life expectation, how are those conditions going to inform our rollout of any vaccine?
Through you, Mr. Mayor, I think there's the two questions. One is, will we use income as one of the criteria for defining where the rollout is? And absolutely, we look across all of the social determinants to look at that and where it might be that it should roll out. In terms of the analysis and whether or not we used their place of residence as a proxy for income in the analysis, I'll just turn to Mackenzie on that point.
Yep, thank you. And that'll be your last question on that, and then I'll turn to Councillor Nan. Go ahead.
Could you put me back on the list, please?
I could.
Thank you.
All right, thank you for your question. And through the chair, we did not necessarily look at that in-house. We do have their place of residence, but that was already looked at as part of the Social Planning and Research Council's work that they had done to look at how to use place of residence as a proxy for linking it to neighborhoods and looking at how that how COVID activity differed based on neighborhood level income and racialized population. So that work has already been done, and it is out there, and those findings align with our findings.
Okay, thank you. I'm going to turn to Councillor Nan.
Thank you. We may have a surprise visitor here a couple of times. My daughter has a cold, so she's home.
She's arrived. I see.
She's arrived. There she goes. Yeah. So in terms of the report, Dr. Richardson, there was reference in terms of the kind of leadership around data collection that was done with Toronto, Peel region, Middlesex, London. And that those regions specifically are also finding similar findings. I was just curious, through you, Mayor, to the team, how are we pursuing best practices or requesting specific resources or discussing the need for intervention with those other regions who are seeing similar trends?
Thank you.
Through you, Mr. Mayor. Generally, it's something that's been seen not only in those specific regions, but in analyses that have been done elsewhere as well. So it's very much a theme of the conversations. Whenever we're having those, whether they're locally here at our PHS table, whether they're at the city EOC table, whether they're at the Hamilton COVID response table, whether they're in our dialogues with the province or other medical officers from around the province, and indeed across the country. So it's that piece about equities is very well appreciated and is part of the discussion at all times about what we can do in order to reduce those inequities.
And as a follow-up through the chair, in terms of getting a sense of what other boards of health may be contemplating as a way of helping guide our priority actions as a result of the information that we have. How is that happening specifically? And I'm just going to pause my mic here for a sec.
Through you, Mr. Mayor. So we continue to get any correspondence that comes from other boards of health, and that is what we pass along to this table for consideration. So you've seen things such as the long-term care home recommendations, such as the basic income endorsement to continue to be endorsed, and we review those, of course, and look at them and make a recommendation for you about what we would suggest in relation to those. There's also there's regular discussions that are happening at the national, local, and what we would call Ontario Health West region levels that are part of the discussion about what are people doing. So they're there. It's ongoing. I will tell you that, if we were not in a state of emergency, essentially across all of our public health colleagues, it might be a little bit more structured in the way we would do that, but we are sharing what we can and ensuring that's top of mind as we go through the discussions.
Okay, thank you. I see Councillor Nan has her hands full, so I'm going to go to Councillor Whitehead.
Thank you, Mr. Mayor. A couple quick questions. First of all, if you do polls the same way all the time, there's a degree of error, 3, 4, 5, some are higher depending on how many people are participating in responses. You indicated that there's a significant number of people that didn't participate in this survey because they may have had COVID, and I think what the numbers are is probably 20 or 50, 60% higher than what is actually reported. So maybe we should deal with that number first. What is the numbers of people actually coming down, potentially coming down with COVID versus the ones that are actually reported?
Through you, Mr. Mayor, there's been a piece that's been discussed as we've gone forward. You know, we started off at the beginning of this outbreak saying they could be anywhere from 10 to 100 plus infections than there are. In part, that was due to the restrictions on testing that Mackenzie talked about earlier on, because we just, hey, it's a new virus. We didn't have tests until they could be developed by our lab scientists and made available and then scaled up to provide. Mackenzie, do you have a current stat for that?
Yeah, so the Public Health Ontario looked at blood samples from the earlier part of our pandemic, and what they found was that among the blood samples they looked at and used that data to estimate that it's probably about 4 times higher than what's actually reported. And so that was during the early days from about March, I believe, up until June. With our increased testing capacity right now, I'm not exactly sure how many cases we may not be capturing, but during the bulk of the time period for this data, at least, we're capturing about 25% of the cases. At least that's the estimates coming out of Public Health Ontario's seroprevalence study.
I appreciate that. So benchmarking, what benchmarking are we doing? So, for example, in the medical community, you often hear there's a predisposition for certain cultures and so forth for certain diseases, so certain receptiveness. So that would be sort of your benchmarking for some of the diversity. Any of that being done?
Doctor?
Through you, Mr. Mayor, if I'm understanding the question, it's, are we assessing whether certain groups are more vulnerable to the infection, or is it whether they're more likely to present for healthcare?
Well, we know that in certain cases they present for healthcare, but I'm just trying to understand if there's a relationship in the context of different cultures and how they live their culture. Like we just talked about, certain cultures will have much larger generational households within the household. So if one person gets it, there's a chance there's a bigger and broader spread. Two, some people predisposed to certain, like cancer, for example, and other people are not. I don't know if that's a cultural thing, but my understanding is like, is it cyclical disease or whatever that terminology is? There's certain diseases that are more, some cultures are more predisposed to than others. So has there been any benchmarking or any understanding of benchmarking in the context of COVID as pertains to that piece? Because we know that the social determinants of your health in regards to all the complications you may have, your income, your access to diet, your access to, or your exposure to the COVID itself, all play a part in those numbers.
Through you, Mr. Mayor, I'll just ask Mackenzie if he wants to comment.
This is, I think, gets back to a root question for this data about why are we seeing these disparities? So what is some of the drivers behind these disparities, or why are they being caused? And I know that this is still an area of active research to try and figure out why some of this is happening. Is there any biological basis to some of these differences, or is it strictly social a basis that is driving the disparities that we're seeing. So I don't have an answer for you because this is still a very active area of research with no firm conclusions yet.
So my last question is, the findings you have in the context of social determinants are consistent with almost any, like SARS, H1N1, flu, most ailments. The same numbers come up in regards to income and certain diversity get impacted to a greater degree. Is that correct? Is this consistent with other findings of other studies on other than COVID-19?
You're on mute right now.
Thank you, Mr. Mayor.
Thank you.
Sorry about that. Through you, Mr. Mayor, then I'll ask Mackenzie to comment as well. You know, absolutely, the social determinants of health are the social determinants of health, and it broadly for all of our health status and our diseases. But that said, there are still some differences, some nuances that depend on the disease, where it occurs, what's happening. And Mackenzie pointed out an important one with healthcare workers, where because they are caring for people who have COVID-19, they are at higher risk as a result. And, then we have the whole social determinants of those who are in certain types of jobs within healthcare and how that plays out. So it becomes somewhat complicated and interconnected in terms of the impacts. But Mackenzie, do you want to add anything there?
Yes, I think it is important to point out that the interaction between our social determinants and people's lives in general are quite complex issues that require a fair degree of unraveling to figure it out. But in general, yes, these income and racialized individuals are more likely to be impacted by various other health outcomes, whether they're infectious diseases or not infectious diseases.
Thank you. Councillor Whitehead, that's time.
Yeah, I appreciate it. And I just want to thank all the good work that Public Health Department and all the other workers have been doing on this front. Thank you.
Great, thank you. I just want to remind folks that Public Works is scheduled to log in at 1 o'clock. And I think some folks here might need a break. Are you on Public Works, Lauren? No? Okay. Second time, Councillor Wilson and Councillor Nunn. Councillor Wilson.
Thank you. Back to some of the lessons, perhaps, that we could learn. Dr. Richardson, my understanding is that when it comes to the number of COVID cases that were felt in our shelter system, it was significantly smaller here in Hamilton compared to Toronto. So the last figure I looked at, we had a total of 4 or 5 cases in our shelters compared to Toronto, where the number at my last count was about 660. A, can you confirm that? And B, would you mind walking us through why that might be the case and whether there are any lessons we could take from that for how we're moving forward on the outcomes that you've revealed in this report?
Through you, Mr. Mayor, I'll start off, and then I might turn to Michelle or one of the AMOHs just to see if they have other comment. But we've been very fortunate in Hamilton, and it's not just luck to have had a lower number of cases here. It was, again, as part of our planning, we worked very closely with the EOC, with housing, to put in place measures to distance within the shelters, to set up an isolation shelter, to, if you recall, the large additional spaces that were put in place so that there was the ability to do distancing. We did start doing testing early, thanks to our HamSmart colleagues, who were doing the screening and working with our public health nurses to do that. So we took a number of measures early on, right off the bat, to try and reduce the likelihood of spread within those communities. There are, I'm sure there's some element of luck as well that we didn't have somebody come in and they were quickly identified and all those sorts of things through the screening and whatnot that happened. But I'll just turn to Michelle, see if there's anything more you want to add there, or to Paul too.
Thank you. Michelle?
Yes, through you, Mr. Mayor. So that is correct that we just had a very small number. I don't know the exact number, but it is 4 or 5 cases within the shelter system. And I think all of the points that Dr. Richardson made are quite valid. I think the other piece that we did very well is we identified very early on that the shelter system in Hamilton houses some of our most vulnerable individuals. So there was a lot of focus and collaborative work across housing, public health, and the shelter system to recognize and acknowledge basically what the impacts could be and to work collaboratively to ensure that anyone who is symptomatic was quickly tested and isolated away, whether that be staff or residents. So I think that there was a lot of good work that happened that had that positive outcome for us.
Thank you. And Mackenzie or
Michelle, if I could just follow up, you made a reference to the testing, the COVID testing that was that allowed for that quick response, and I'm assuming that that testing was available for staff too, which may have helped in the securement of staff.
Yes, that's correct. So in the shelter system in Hamilton, 2 things were happening for testing. Both the residents and staff were tested, and that testing was actually happening on a weekly basis for surveillance purposes. And then if there was anyone symptomatic, they too could be tested right away, regardless of where that happened to fall in the week. So it was happening on both fronts.
Okay. So I guess my question is the importance of that testing and that intervention, and then if we can extrapolate anything from that into these results that are before us now in terms of who's getting tested, how are they getting there? And I thought I heard Dr. Richardson make a comment of mobile testing units, but I wasn't sure. So I'd like to ask that last question.
So I think it is really very important through you, Mr. Mayor, to just talk to the issue of testing. And, there have been changes made to the testing criteria. We've seen over time that asymptomatic testing is not very helpful in that it produces a large number of false positives. And so in some settings, it's not so great, but certainly rapid access to testing for anybody who's asymptomatic. It was important for us to establish with the shelters, what was going on. And so HamSmart and that work was important to do that, just as they tried to do with temporary farm workers as well. But then to find, for anybody who's symptomatic to be able to get quick access to testing, to be able to isolate quickly has been very, very important to do. And so that's the case, on every front. It's one of the measures we look at. How quickly can people access testing is one of the reasons why we were so concerned as testing numbers went up. The testing requests went up and the time to get into testing got prolonged. We were managing for our outbreaks and whatnot to try and get those tests in very quickly, but that whole backlog in the system was very, very concerning for us the couple of times that it has occurred. So quick access to testing and quick intervention in cases where there's illness have been very, very important parts of what we do. But I can't underscore the importance of prevention enough. And so, while we talk about testing as something you do, we always talk about that upstream, downstream analogy. That's more of the downstream piece. What's been very, very important to do is the upstream piece of getting in, making sure that there's the resources, that there's IPAC measures that are in place in these facilities and in other facilities in order to prevent the virus from coming in initially and from spreading once it's in. And so I think that's indeed where a lot of our success was.
Okay, thank you. I'm mindful of quorum. I'm getting messages now that some folks have to leave, and I think we're at bare quorum right now. So let's have a motion to receive this report, please. Moved by Wilson, seconded by Whitehead. Sorry? A question? No, I think she wanted to second it. You have a question?
No, I did have a question. Just one final one, and I do realize people have public works this afternoon, but to Dr. Richardson, you can tell the focus of my question is in what lessons can we learn and who we're talking to so that when eventually it does come to the point of vaccination, we're as successful as possible. And would you see any value in, or were there any plans to distribute the report that you've provided to some of our community partners, whether they be the city's own advisory committee? We have people with disabilities. We have of course, LGBTQ community. We have the anti-racism community. We have an immigrant and refugee committee, advisory committee. Would there be an opportunity to share the report with them because they have, they could look at it and maybe inform us of their experience or ideas of how to improve?
Thank you. Dr. Richardson. Yep, coming up. 1 second, there we go.
Okay, there we go. Through you, Mr. Mayor, there aren't currently plans to take it to the other advisory committees, but if that was helpful to do, we would be happy to send it on to them for and receive back their comments.
So, Mr. Mayor, I would respectfully request that we could do that with that thoughtful direction.
Okay, I'll leave that as a thoughtful direction then. Thank you. I'm going to turn now to a motion on receiving the report, moved by, again, Councillor Whitehead, seconded by Ferguson. All in favor, electronic vote, please. Any of those that cannot vote, give me the thumbs up. And if those that are on the call, please turn your videos on so we can see you. Thumbs up from Councillor Marula. Oh, the presentation and then the report? Okay. All right. And anyone else need to do that? Thumbs up. Why is that? I haven't seen a vote come through yet. Thumbs up for me. Didn't pop up. Thank you. And then we are going into camera. I trust briefly, but don't see her. Okay, second vote is on the report itself. I would have done an omnibus bill on a vote on that one, but not showing up on my screen again, so thumbs up. Thumbs up from anyone else? Councillor Clark, thumbs up from Councillor Marula. Anyone else? Councillor Ferguson, thumbs up, thank you. Councillor Whitehead, thumbs up. Thank you. I'm going to go on a giant limb here and presume that that's carried, and it is. Thank you, and I need a motion to go to respecting items 13.2 and 13.7 pursuant to section 1 subsection E and F of this procedural bylaw 18270 as amended in section 2392 subsection E and F of the Ontario Municipal Act as amended as the subject matter pertains to E, litigation or potential litigation, including matters before administrative tribunals affecting the municipality or local board. F, advice that is subject to solicitor-client privilege, including communications necessary for that purpose. And we will require an electronic vote on that. So all in favor of moving into camera, please indicate. And for those that cannot vote, thumbs up, Councillor Marula, thumbs up, Councillor Clark, thumbs up, Councillor Johnson, thumbs up, Councillor Vanderbeek, thumbs up, Councillor Farr, and Ferguson. We shouldn't be enclosed as yet. But you know what? I'll take a thumbs up vote on this in the interest of time. So no one's objecting, and Councillor Jackson is enthusiastically thumbing it up. Okay, so that's carried. Thank you. The in-camera item now is before us, residential care facility. We do have to go into camera though, so we'll give them a moment to set up. I'll catch the inside joke later. Someone required an emerge, though. That's what I recall. Clerk, you'll let me know when we're properly in open session. Yep. Okay, we are fully open in open session. Hopefully you're in the open portion of the meeting. I need a motion on the report BOH 2019-2026 respecting the residential care facility update that will remain confidential. Moved by, I'll take volunteers, Councillor Pearson, and seconded by Councillor Collins. All in favor, electronic vote, and I'll take thumbs up for those that can't. Showing up, actually, unusual for me. Thank you. Thumbs up for anyone else. Councillor Clark, Councillor Marula, Councillor, anyone else? Apparently not. Very good. And that was quick. Thank you. And thank you all very much for a great meeting. Thank you, staff, for all your great answers and reporting. And Public Works will be along, I think, starting around 1 o'clock. I'll take a motion to adjourn. Moved by Jackson, seconded by Ferguson. All in electronically? Yeah, unfortunately, electronically. Oh, I like old school. Anyone else needs to do a thumbs up? Councillor Clark, I see. Councillor Johnson, thank you. Thumbs up. And that should be everybody. All right. Thank you, folks. That's carried. Have a good meeting.